Hello, I'm Joseph Alpert, Professor of Medicine and Cardiology at the University of Arizona in Tucson, Arizona. I'm also the Editor-in-Chief of the American Journal of Medicine. This is the first of a series of 10 lectures that's going to give an introduction to how to read an electrocardiogram. The electrocardiogram is one of the most useful and simple diagnostic tests that we have as cardiologists and as internists, and it can be mastered with a little bit of effort and a lot of practice. At the end of this lecture series, you will not be an expert in reading electrocardiogram, but you will understand and be able to read most of the fairly straightforward electrocardiograms. There will still be some subtle ones that are difficult, and the answer to that, of course, is practice, 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 just like you were learning to play a musical instrument. You're not ready to perform in public after 10 lessons, but you will be quite familiar with the electrocardiogram following this series. So let's get started. First of all, it turns out that the human brain is particularly good at recognizing patterns. And this is a genetic characteristic that was probably evolved millions and millions of years ago when you needed to recognize what was out there in front of you was something that might be able to be eaten or something that was looking to eat you. So that's exactly what happens with the electrocardiogram. After a while, when you become very expert, your brain allows you to recognize the pattern immediately when you see it. Now, of course, there's going to be some steps where you're going to have to make some measurements, but in fact, you will immediately know, oh, I recognize that. That's a heart attack, and so forth. So, I think after the end of this 10 lecture series, you'll be able to do that, and with practice, you'll get very good at it. So, I'm sure you recognize immediately these two paintings, right? On the left is Van Gogh's Starry Sky. On the right is Leonardo da Vinci's Mona Lisa. How did you recognize them immediately? Because you know the pattern, you've seen them so many times. In the end, I think you'll get to be able to read the electrocardiogram in a very similar way. You'll immediately recognize something, and then you'll go back and do a little more detailed work on it. So when did the electrocardiogram start? It started in the early 20th century. A Dutch physician named Einthoven was the first to be able to record the electrical activity of the heart with any accuracy. Many had tried before, but he was the first that was successful. Now you can see from this very primitive early electrocardiogram, one had to have an arm in salt water and a leg in salt water and a huge apparatus in order to record the electrocardiogram. Well, today, of course, with solid state instruments, they're much more sophisticated. The amplification makes the images much clearer, and we now use a very standardized protocol all over the world. And the standards were arrived at a long time ago, back in the 1930s, by experts who came together to decide what would be the universal rules for an electrocardiogram. Reading the electrocardiogram, as I said, it's like examining a fine artwork. First of all, you get an overall impression. Something leaps out at you, particularly if it's acute heart attack, acute myocardial infarction, as we'll talk about. But then secondly, there has to be the more careful, detailed analysis, things like heart rate and the duration of the various intervals, and we're going to go over that now. So in the beginning, don't hurry, take your time, systematically check the heart rate, the timing of the intervals, and the presence or absence of P waves. And we're going to talk about what that means in a moment. Remember, many times you're going to be seeing an electrocardiogram that's been recorded by a computer, and the computer will have read a diagnosis. It'll give you some information. The computers usually write about heart rate and intervals, but it's often not right about the underlying rhythm, and sometimes it even makes more serious mistakes. So every computerized electrocardiogram has to be overread by an experienced electrocardiographer. So the first thing you're going to look at is going to be the heart rate. That's the number of beats per minute. I'm going to give you a rule how you can calculate the heart rate from the EKG. Of course, it will already have been calculated for you if it's a computer-read ECG. Then we're going to do the various intervals. That's the various points on the electrocardiographic complex that you see on the right-hand side. And we're going to go over how those intervals are derived and how long they are when it's normal. So let's start. The first wave in the electrocardiogram is the P wave, and this is the electrical signal made when the atria, that's the upper chambers, depolarize. Now you're going to ask, why P, Q, R, S, and T? Why not A, B, C, D, and E? Well, in fact, in the early years where there were attempts in the early 20th century to try and record the electrocardiogram, there were many artifacts that were called A, B, and C, and D, and so forth, all the way through the alphabet. And finally, Einthoven got to the letters P, Q, R, S, and T, which were the accurate ones. So all the earlier ones were artifacts. So that's why we use these terms. So here is a normal complex. You'll notice the P wave, that's the electrical depolarization, the wave of electricity running down through the atria, and then it arrives at the ventricle. That's the QRS, that big complex is the ventricle. Ventricle has much more heart muscle, so therefore it's a much bigger complex. And then you have something called the ST segment, which is a little pause before the ventricle resets itself, and the resetting is the T wave. And some patients will have a U wave following the T wave. This can be normal. It's absent in most electrocardiograms, and it is a little more commonly seen when patients have low blood potassium, so-called hypokalemia. So here again are the various segments. You'll notice that the so-called PR segment is the segment that runs all the way from the beginning of the P wave to the QRS. It's divided into two segments, the duration of the P wave and then the PR segment, that is from the end of the P wave to the beginning of the QRS. But for most daily reading of the electrocardiogram, we just call the PR segment the entire period from the beginning of the P wave to the beginning of the QRS. You then see in gray the QRS complex. That's the depolarization of the ventricle, of both ventricles, by the way, right and left, although the left has a lot more muscle, so the QRS is dominated by left ventricular muscle depolarization. There's then an ST segment, where a little pause while the ventricle finishes the depolarization and gets ready to repolarize, that is to get ready for the next beat, and that's during the T wave. The T wave is the repolarization wave, and then as I mentioned, the U wave is often not present, but may be present as a very small wave following the T wave. The electrocardiogram is usually the first test done after the history and physical exam. It's often done in offices. It's very simple, and many physicians' offices have their own system. Usually it's done by a technician. In the office, it may be done by the office nurse. In the hospital, there's a whole series of technicians who are on 24 hours a day to record accurate electrocardiograms. It is, again, the simplest, cheapest, and most easily obtained cardiovascular test. It has reasonable accuracy for a variety of heart conditions, for example, arrhythmias or myocardial infarction, a heart attack. However, it's not as accurate at determining the volume of heart muscle compared to an MRI, an echo, or a CT scan. But all of those are much more expensive. They require huge amounts of equipment and machinery. The electrocardiogram is really inexpensive and very simple, and is almost always the first test done. One of the reasons it takes a long time to learn to read an electrocardiogram is there are many non-specific or non-diagnostic patterns, and there are some differences between men and women and between different groups. For example, in the United States, African Americans have slightly different normal values from European white males and so forth. So all of this, of course, is in the computer, and the computer is told before the EKG is taken what the patient's ethnic background is and so forth. So that helps in terms of the normals. And also you'll get to recognize these things as you practice reading many electrocardiograms. So let's go through the electrical activity in the heart. So when a myocardial cell depolarizes, that is, it has a resting potential electric current across its membrane, and then suddenly that goes to zero. When that happens in a process called the action potential, it results in a trigger of the myocardial contractile machinery. So you have the electrical depolarization, contraction, electrical depolarization, contraction. So there is a pacemaker which spontaneously depolarizes high in the right atrium. That's the little round green dot high in the right atrium on the diagram on the left here. And that area has very specialized myocardial cells. They depolarize spontaneously. Sodium spontaneously leaks into the cell through some channels that are called the funny channels, because no other sodium channel leaks like this. And when they get to a certain point, it triggers the action potential. And then what happens is the wave of electrical depolarization passes from the sinus node through the atria down into the septum between the two ventricles. There's a pause at the AV node, and that's the second little round green circle. Why a pause? Because if it went immediately into the ventricle, both the atria and the ventricle would be contracting at the same time. Not a good idea, because then nothing would go out the aorta. There would be no effective cardiac output. So there's a pause while the atria finishes its contraction, filling the ventricles, and then the wave of depolarization passes down past the AV node into the His-Purkinje system and throughout the ventricle, passing down first the septum to the apex and then backwards to the base of the heart. And when that happens, it triggers contraction and the ventricle squeezes. And here you see, here's a whole series of action potentials for the different myocardial cells as the wave of depolarization passes down. This is you'll see the action potential for the sinus node, which is, as you can see, slowly rising. There's a spontaneous depolarization. But once you get into the atria and to the ventricle, the depolarization is not spontaneous. It's immediate as the wave of depolarization arrives. And so then here we see again going down through the atrium and into past the mitral valve, past the tricuspid valve, into the ventricle. You're in the His-Purkinje system now, and then eventually you finish and you get to the T wave as everything resets itself, getting ready for the next beat. It's interesting that the wave of depolarization doesn't go through the ventricle all at the same place. It comes down the septum, arrives at the apex, and then turns back and does the base. So what that means is that if you're an observer, you're an electrode watching this, when the electrical current and the wave of depolarization is coming towards you, the EKG records an upstroke. When the electrical depolarization passes the apex and starts to go back towards the base, in other words, going away from an electrode, you see a negative deflection. And that's why, for example, you saw on the QRS, there's some positive and there's some negative. Depending on where the electrode is looking, if the electrode's looking from here, it's going to see different than if the electrode's looking from here, because the wave of depolarization from here will be coming towards this one at a certain point when it's going away from the one over here, and vice versa. And we'll see some examples of that. And here in the continuum diagram, you see the wave of depolarization passing from the apex back up to the base until the entire both right and left ventricle have depolarized and have contracted. So it turns out that by convention over the years, the EKG has come to have 12 different leads, that is 12 different points that are looking at the wave of depolarization going down through the heart. And the earliest ones from Eindhoven were so-called leads 1, 2, and 3. So these leads are all designated by the points on a compass, 0 to 360 degrees. Lead 1 is over here, and it's looking in at the heart from the left point, like the left arm in, and that is designated as 0 degrees. Lead 2 is looking from here, that's plus 60 degrees, and lead 3 is looking from here, that's plus 120 degrees. Well, over the years, there have been additional leads added, and these are the so-called augmented leads, leads AVR, AVL, and AVF. Lead AVF is looking from straight down below, that's plus 90 degrees. AVL is looking from minus 30, that's up here. And AVR is looking from plus 120 from way over here on the right arm. These are all looking in a frontal plane, just as if we were a flat plane that the body was standing in. So here we see again the leads I said before, the Eindhoven leads. Lead 1 coming in from the left arm, that's 0 degrees. Lead 2 plus 60 degrees coming from here. And lead 3, 120 degrees plus. We also have leads that are cutting the heart right down in a section, just as if it were right through the body like this. Those leads are placed on the chest out here. Here's lead 1. Lead 2, 3, and 4, starting at the right sternal border and working around to the axilla. And they give you views of the depolarization wave in a so-called sagittal or cross-sectional plane. And that's V1, 2, 3, 4, 5, and 6. And all of these leads, the ones we said before, lead 1, 2, and 3, AVR, AVL, and AVF, V1, 2, 3, 4, 5, and 6, are all printed out on a piece of paper or appear on a computer screen for interpretation. So let's start with the most basic way of interpreting the ECG. The first thing you do is you have to check the voltage calibration. What's this about? This is about the amplification of the image that the ECG machine is going. Sometimes with arrhythmias, we want to enlarge the complexes, so we will double the amplification of the image. But usually, for almost all routine ECGs, the calibration is so-called 10 millimeters. That's 10 little boxes, and we'll show you examples of that. And it's always good to check that to begin with, because if they had been using the machine at a higher amplification, the complexes are going to look bizarre. They're going to be big and so forth, and you might make a mistake in reading. So first, make sure that the calibration is correct. Usually the technician takes care of that. But there's a little box that shows you the calibration is okay, and I'll point that out later. The next thing is to determine the rhythm. And how do you do that? You're looking for P waves followed by QRSs. In other words, the normal progression. Remember, starting up with the sinus node, atrial depolarization, P wave, QRS, ventricular depolarization, T wave resetting. Once you know what the rhythm is, in other words, is this a normal sinus rhythm or is it not normal sinus rhythm but an arrhythmia? And we're going to have whole lectures about the kinds of abnormal electrical events that can occur when it's not sinus rhythm. You then calculate the heart rate, which is, there's normals there, and I'm going to be going over the normals as we go along. You then do the timing intervals. What's the PR interval from the beginning of the P wave to the beginning of the QRS? What's the QRS duration? That's the period of ventricular depolarization. And then how long does it take for the whole contraction and resetting of the ventricle from the Q wave to the end of the T wave? We would then determine the electrical axis. In other words, what is the main vector force of the electrical depolarization wave? What direction is it going in? And there's a certain normal area for that. And for example, if you have abnormalities of the ventricular mass, you can get abnormal vectors, abnormal electrical vectors. We want to look at the P wave morphology to see if it's normal. We look at its voltage and its shape because certain abnormalities of P wave morphology can occur with certain diseases. We want to do the same for the QRS morphology. Again, certain diseases, and for example, heart blocks, things that can lead to pacemakers, will change the morphology of the QRS. We'll then look at the ST segment and the T-wave morphology. Ischemia, lack of blood flow in the heart that can lead to angina or heart attacks, changes the ST segment and T-wave morphology. And if we're lucky enough to have an earlier baseline EKG, we compare it to see, hey, have there been changes? Is something going on here that's something acute? So let's start. Here is a normal ECG. Notice in the upper left corner, there is a little green box. That's the standard. And that standard is, if you count the little tiny boxes, 10 little boxes. Each one of the big boxes has 5 smaller boxes. So there'll be 2 of the big boxes, which constitute 10 small boxes. Each one of those boxes is 1 millimeter and corresponds to 1 millivolt of electrical activity. Again, this is the standard on all ECG machines. And if you had set the standard to half, then of course it would be each one of those little boxes would be less voltage. If you doubled it, they would be more voltage. But usually, again, almost all EKGs use this green box of the 10 standard. You'll notice how the leads are placed here. On the left-hand side, there's lead 1, 2, and 3. Remember, 0 degree, plus 60, plus 120. The next three leads, AVR, L, and F. AVR plus 210, AVL minus 30, AVF plus 90. And then come the precordial leads, the ones that are sticking through the heart like needles in a sagittal plane. V1, V2, V3, 4, 5, and 6. And this is a normal ECG. Notice there's a P wave in front of each QRS. The QRSs are nice and narrow. There's a nice T wave upright and not way prolonged after each QRS. This is sinus rhythm, normal sinus rhythm that's set off by the sinus node, passes normally through the heart. There's no evidence here of ischemia or heart attack or hypertrophy of the heart muscle. As I said, you'll notice that there's sinus rhythm. In the green box, you'll see that each QRS is preceded by a P wave. The atrium depolarizes before the ventricle. All the P waves are followed by a QRS. There's no blockage of the beat as it goes down through the heart. Each QRS is preceded by a P, and the P's are all identical. They're upright in leads 2 and AVF, and they're nice and narrow. They're not prolonged. If any of the comments just made the answer was no, then you're talking about an arrhythmia. And as I said, we're going to have whole lectures on the arrhythmias later. So right now we're just worrying about the normal. Also, you notice how nicely the QRSs progress. In fact, that whole strip along the bottom, even though they're different leads, it's continuous. So you're actually seeing one set of P waves after another. In order to obtain the heart rate, you count the number of big boxes between two QRSs and you divide by 300. So if there were 2 big boxes between the 2 QRSs, that would be 2 into 300 or 150. If there were 3 big boxes in between a QRS, that would be a rate of 100, 3 into 300. If there were 4 boxes in between the 2 QRSs, that would be 75. 4 into 300 is 75. You can also do it by counting the number of QRSs in 3 seconds. Remember, the ECG is moving at a certain rate. You can calculate a number of seconds and then multiply by 20, but usually what we do is we use the rule of 300 mentioned before. It's important to note that the normal heartbeat is 60 to 100 beats per minute. So now we have the heart rate. By the way, the computer's almost always right on the heart rate. Again, let's talk about the intervals. So a normal PR interval is 0.2 seconds to 0.20 seconds. That's 3 little boxes to 5 little boxes, right? You remember there's 5 little boxes within the bigger box. So the normal PR interval from the beginning of the P wave to the beginning of the QRS is somewhere between 3 and 5 little boxes, 0.12 to 0.20 seconds. The normal QRS interval is less than 0.1. That's 2.5 little boxes. And the normal QT, which is corrected for heart rate in a formula, is somewhere between 0.3 and 0.46 seconds. Remember the QT from the beginning of the Q wave to the end of the T wave. Remember, each small box is 0.04 seconds, so a large box is 5 times 0.04 seconds, or 0.20 seconds, and there are 5 small boxes in each large box, as I've said before. Again, what about the axis? Well, there's a general rule that most med students use, and that is, if the QRS is upright in leads 1 and 2, it's a normal axis. You can actually calculate the axis because the axis is perpendicular to any lead where the R and the S, or the upstroke and the downstroke, are equal. In this example, lead 3. You see that pretty much the amount above the line and below the line is about the same. So the axis is going to be 90 degrees from lead 3. So 90 degrees plus 120, lead 3 is 120, remember, that's 210. And that would be, in other words, the axis would be towards AVR, or minus 90 from 120 would be 30. That would be somewhere near lead 2, which is plus 60. Well, you can see, how do we tell? Where is the maximum R wave? Well, the maximum R wave is around lead 2. There's no upright R wave in AVR, so therefore the axis is actually something like a plus 30. So again, the rule of thumb is you look to see where the amount of voltage up and down is equal. It's 90, the axis is 90 degrees from that. Then you look for the lead with the maximum R wave. That's the direction, because you could go this way on the 90 degrees or you could go that way. What tells you which way you go is where's the maximum R wave. In this one, it's lead 2. And again, normal axis is between minus 30 and plus 90. And if the axis is not between minus 30 and plus 90, then it's an axis deviation. If it goes more minus, that's so-called left axis deviation. If it goes more plus than 90, it's called right axis deviation. And we'll talk about how that's used in reading various electrocardiographic diagnoses. So again, just to reiterate, the axis for the mean frontal plane electrical vector of the heart is near the limb lead with the tallest R wave and perpendicular to the lead where the size of the upward deflection and the downward deflection are equal. Remember, the upward deflection is called an R wave, the downward deflection is called an S wave. So let's take a look at the P wave itself. The normal P wave is going to be 3 little boxes or less in duration. Remember that the PR interval, that's the duration from the beginning of the P wave to the beginning of the QRS, is going to be less than 5 little boxes. But the length of the P wave itself should be only 3 little boxes. And it should be upright in lead 1 and 2, and a negative deflection of less than 1 box wide or 1 box deep in V1. If the P wave in lead V1 is more negative than 1 box and wider than 1 box, that suggests that the left atrium is enlarged, so-called left atrial enlargement. If the box is pointed and higher than 2 millimeters, then and usually wider than 2, then that defines right atrial enlargement. Now, these numbers are not anatomically perfect. The echo and the MRI and so forth will be more perfect, but they carry prognostic information. They're very important because when they appear, it really means that there's quite significant either left atrial dilatation or right atrial dilatation. Let's look at the R wave now. The normal R wave should transit in the precordial lead. Starting with lead V1, there should be a very small R wave, and then it gets a little bigger in V2, and somewhere between V3 and V4, you have a dominant R wave with not much S wave, and then it progresses out to V6 with usually the maximum R wave somewhere in V4, 5, and 6. With the transition from more negative to positive somewhere around V3 or V4. Small Qs, that is initial downward deflections of less than 1 little box, can occur, but they are never longer than 1 box. If they're wider than 1 box, it suggests that there's been damage to the myocardium. And the voltage should be within a normal range. Also, the ST segment should be isoelectric, that is, it should be flat. You can have a little bit of depression, but if it's substantially depressed more than a tiny amount, it suggests a number of things. Let's look at what it suggests. If there's a sort of curved sagging of the ST segment, as in this example, that means the patient is usually taking digitalis. Digitalis has that effect. If there's ischemia or lack of blood flow, you see a squared off flattening of the ST segment. We see that with positive exercise tests, and we see that when patients come in and have so-called non-ST elevation myocardial infarct, and we'll talk more about those definitions later. And then in hypokalemia, where the potassium is low, you may see a mildly downsloping ST segment. The T wave is often flattened, and as I mentioned before, you may see a little additional wave after the T wave, the U wave. Again, Here's the normal EKG. Look at the ST segments here. They're all fine. They're not depressed. They're not elevated. They're in exactly the right sequence. Well, we've covered a lot of important definition material, and you may need to repeat this lecture a couple of times to make sure you have all of the numbers down, or you may have taken notes on that so you remember it. Once you start reading EKGs, it'll become easy to remember what the various intervals should be. Oh, the PR needs to be less than 5 little boxes and so forth. Let's do a case. Okay, here's a 22-year-old male student who's the captain of the university boxing team, and he comes into you because he's having anterior, that is pain in the front of his chest. The discomfort occurs several times each day and lasts for 1 to 2 hours. On physical exam, he's very tender when you touch the sternum, and he did admit that during a number of boxing matches recently, he took a number of hits on the sternum. By the way, what are the important points here? Number 1, chest pain, that's why he was referred. Number 2, there's a history of some thoracic trauma. And here is the EKG. So, it's a normal EKG. It's the one I showed you before. So that's very reassuring, because what were we worried about? Well, we worried that maybe, he'd gotten some injury to the blood vessels in the heart, and maybe had had a heart attack during one of these episodes. So the patient's chest pain is musculoskeletal in origin. It's the result of the trauma that he suffered when he was boxing, and you can reassure the patient it'll get better with time. The treatment, you could give some nonsteroidal anti-inflammatory agents such as naproxen and reassurance, and no further testing is required. Hello, I'm Joseph Alpert, and in this talk we are going to go over the EKG changes that occur with myocardial infarction. This is one of the most important uses for the electrocardiogram. Early recognition of myocardial infarction enables effective therapy, for example, reopening a blocked coronary artery to occur, which markedly improves the survivability of the patient. So again, let's just have a little review. Remember that the electrocardiogram shows the electrical depolarization of the heart. It's a simple, cheap, easy test, often done in offices and hospitals everywhere. It's almost always the first cardiac test that's done. It's accurate for ischemia and acute myocardial infarction, that is a heart attack. It's also quite accurate on ventricular hypertrophy, that is enlargement of the ventricle muscle, and also for arrhythmias. And remember, there are many nonspecific and non-diagnostic patterns, which is why one has to practice a lot to recognize when something on the electrocardiogram doesn't mean anything. An acute myocardial infarction is a heart attack. It causes changes on the electrocardiogram in the T waves, in the ST segment, and with the development of Q waves. Q waves that were not present in the normal ECG that developed during a myocardial infarct represent literally holes in the heart, that is, electrical holes where there's no viable myocardial cells left. Remember this diagram? This is the normal electrocardiographic complex. Notice in yellow, the P wave, usually 3 little boxes or less in duration, and then a short segment between the P wave and the QRS. The entire yellow and orange section is referred to as the PR segment on the electrocardiogram. In gray, the QRS complex, that's ventricular depolarization. Then we have an ST segment that's usually flat, followed by a T wave, which is the repolarization wave of the heart as it resets itself for the next beat. And the U wave sometimes occurs very often in patients with low blood potassium. Here is a normal sinus rhythm. Notice, we talked about this in earlier slides and in earlier lectures, the P wave comes just before the QRS, and it is less than 5 little boxes from the beginning of the P wave to the beginning of the QRS, and these are normal ECG complexes, nice narrow QRS. And you've seen this normal ECG before. This is somebody with nice normal progression of the R waves across the precordium from almost a tiny R wave in lead V1 to a dominant R wave in V4, 5, and 6 as it goes over the left ventricle. And also the axis is normal with the maximum R wave in lead 2. And the T waves are all upright. It's a nice normal ECG. So now let's look at some ECGs of acute myocardial infarction. By the way, just to bear in mind that not only does the ECG help you in terms of the diagnosis of MI, but depending upon the extent of number of the changes, it gives you prognostic information. In other words, how bad is this heart attack? We have some EKGs that look like small amounts of injury to the heart, and some EKGs that look like big bad injury to the heart. This is really going to be dangerous and may impair the patient's ability to survive down the road. Acute MI presents as either ST segment elevation or ST segment depression, and often associated with inverted T waves, as you're going to see. Depending on where the changes occur, it gives us a rough idea of the location of the myocardial infarct. So the leads that look at the bottom of the heart, remember lead 2, lead 3, and lead AVF from down below, those show us heart attacks on the inferior or posterior of the back, either the underside or the back of the heart. That's the inferior leads. The leads V1 and V2 show us the anteroseptal region, that is partly the septum and part of the anterior wall. Leads V3 and V4 generally show you the main area of the anterior wall, and 5 and 6 show you the anterior wall and some of the lateral wall. Leads 1 and AVL show you the lateral wall. So you can see we get a rough idea of where the infarct is from where the abnormalities occur with a heart attack. And again, here's just a little review. Leads 2, 3, and AVF, inferior, or sometimes called inferior posterior. Leads V1, V2, septal, anteroseptal. V3, V4, anterior, V5 and 6, lateral. Also leads 1 and AVL lateral. So very often a lateral infarct you'll see leads changes in lead 1, AVL, V5, and V6. ST elevation myocardial infarction are the worst. They imply a large amount of myocardium that's ischemic with considerable damage and have a worse prognosis than the ST depression, so-called non-ST elevation MIs. As stated here, the non-ST elevation MIs show ST segment depression. They're smaller than the ST elevation MIs. By the way, ST segment depression can occur with myocardial ischemia, with angina, and then goes back to baseline when the patient rests. And it's also a finding when we do an exercise test. The ST segments depress when there's ischemia, and then in the rest period after the exercise test, they come back to normal. So let's go over a little bit about the ST segments. They should normally be flat. They should be the same flat and direction as the segment, the PR segment, nice and flat. In fact, there are multiple causes of ST segment depression, as I mentioned in the very first lecture. Ischemia is the one we're most interested in. Electrolytes like hypokalemia can cause ST segment changes, and digitalis therapy can do the same. You've seen this slide before. Remember, the digeffect causes a sort of rounded sagging of the ST segment. Ischemia causes a flattened, squared off ST segment depression, and hypokalemia usually a sort of somewhat slower downward slope with a flattened T wave and sometimes a U wave following. Here's some more examples. Here's minimal ST segment depression, so this might be associated with a very small infarct. Here's what I call big league ST depression, going to be associated with a much larger non-ST elevation MI. The minor amounts of ischemia you saw above can be seen with a positive exercise test or with angina that reverses itself. The kind of ST depression you see down below, the huge amounts, are usually going to cause some cell death and a myocardial infarct. Again, reviewing where the occlusion may have occurred, here the inferior wall is often supplied by the right coronary artery in 90% of patients. In 10% of patients, it's the left circumflex that supplies the inferior surface. So if you see an infarct pattern, an ST elevation or depression in leads 2, 3, and AVF, it's usually going to be the right coronary artery that's involved. If it's any one of the V leads, either the septal, anterior, or lateral, then it's usually going to be the left anterior descending that's doing it. And if it's pure lateral, it's usually the left circumflex. It's not 100%, but it gives you a rough idea. And the people in the cath lab who are going to be going in to open up the artery will look at the EKG to decide which artery they're going to look at first to consider opening up with an angioplasty. So, this is an acute inferior wall myocardial infarction. Notice, let's look at leads 2, 3, and AVF. Remember, those are the inferior leads. 2, 3, and AVF, look at the ST elevation that you see here. That ST elevation, now marked in the green boxes, is quite impressive. It's probably about 3 or 3.5 millimeters, and it suggests, oh, this is an inferior MI. Right coronary is probably involved, or at least in the vast majority of cases. Notice, how do we know that this ST elevation is real? We know it because leads 1 and AVL that are looking from a different direction actually have the opposite. They have ST segment depression. This is a mirror image of the ST elevation in leads 2, 3, and AVF, and it tells you this is the real thing. So this is good evidence that the ST elevation is an acute MI and not from some other cause. Again, here we see another example of an ST elevation in leads 2, 3, and AVF. And by the way, also sometimes we'll do right-sided leads that go further out than V1. They give us some image of what's the electrical activity in the right ventricle. You'll notice that there's some ST elevation in so-called lead right V4, and that's telling us that the right ventricle is also involved, which happens because, remember, the right coronary artery supplies not only the back of the heart and some of the septum, but it also supplies the right ventricle. So if you have an occlusion, particularly a proximal occlusion of the right coronary, you may have some damage to the right ventricle, just like you're having inferior wall myocardial infarction. There is ST depression again in leads 1 and AVL, reciprocal, so-called reciprocal or mirror image changes saying this is the real thing. So this is an ST segment elevation in the right precordial lead, implies that there's been some involvement of the right ventricle. When you see right ventricular involvement, it usually means a larger myocardial infarct, and the prognosis or the outlook is a little worse. It's more dangerous. Remember, I told you that there's prognostic information in the EKG, not just diagnostic information. Here we see an example of an anterior wall myocardial infarct. Notice that there's ST elevation in all of the 6 precordial leads, a little bit in V1 and a little in V6, but really very impressive, huge ST elevation in leads V2, V3, V4, and even pretty impressive in V5. These very high ST elevations, almost 10 millimeters in size, these have sometimes been called tombstone changes. Why? This is a very, very dangerous myocardial infarct. It's an occlusion, very likely proximal of the left anterior descending coronary artery. A huge amount of heart muscle is threatened. This is a real big emergency. Off to the cath lab as fast as possible and open up the LAD again. So this is a very nasty anterior MI. Here's another one, not quite so nasty. You'll notice ST elevation in leads V1, V2, and V3, and also in AVL. So that suggests that there's a certain lateral component to this. So possibly this is an LAD that has branches in the lateral wall, or it may be even an involvement with the left circumflex and the left anterior descending. It may be that, for example, the patient had a previous narrowing of the circumflex, and when the left anterior descending goes down, there's lack of good blood flow down the circumflex as well. So in any case, this is another example of anterior MI. Also, what's of interest, notice the QRS. Look at the QRS, particularly in leads V1, V2, and partly in V3, there's a Q wave. The QRS starts with a Q wave, starts with the hole in the heart that's electrically gone. And you'll notice also that there's a Q S pattern in lead AVL. Same thing, that this is telling you that there's myocardium that's no longer depolarizing. Again, we point that out. There are Q waves in leads V2, V3, and AVL. And I think if we magnified it enough, there's a little tiny Q wave also in lead V3. So here's some unknowns. Look at this EKG. I'll tell you a clue to start with. There's a myocardial infarct here. Tell me where it is. Is this an acute inferior MI? And the answer is yes. ST elevation in leads 2, 3, and AVF. Also of interest, notice right at the very beginning, there's the standardization, the box that's 10 points high, telling you that this is the right standardization for this EKG. Let's look at another one. Take a look at the next one. I'll also tell you this is an MI. You tell me where it is. Is this an acute anterior? Yes. There's ST elevation in leads V2, V3, V4, and V5. So again, acute anterior, that's LAD, left anterior descending artery. Acute inferior, usually the right coronary, but can be in 10% of people the left circumflex. We see the ST elevation anteriorly. So, as the myocardial infarct heals, the EKG develops these initial Q waves, and usually they stay there. Even years later, the Q waves may tell us, oh, there was an earlier myocardial infarct in this zone. Let's say there were Q waves in 2, 3, and AVF, and the patient said, oh yes, I had a heart attack 10 years ago. Those Q waves are still there because there's a scar there. There's an electrically quiet zone in the scar that shows the infarct had occurred in the past. So with time, the ST elevation comes down and becomes flat again. Usually the T waves then become inverted. And as I mentioned, Q waves can persist as a permanent reminder of the old MI. And then over time, the inverted T waves usually become upright again. So here, how do we know abnormal Q waves? Well, first of all, abnormal Q waves are usually going to be less than one little box, so less than 0.04 seconds and less than 2 millimeters in depth. So that means they're going to be less than one small box wide and less than 2 small boxes deep. And here we see an old EKG. This is an old inferior MI. Do you see leads 2, 3, and AVF? There are very significant Q waves. They're wider than one little box, and particularly in leads 3 and AVF, they're deeper than 2 little boxes. So previous inferior MI. Also notice here that the T waves are inverted. They haven't come back yet. Usually with time, they will come back. So larger Q waves are pathological Q waves. They're usually sign of a prior MI, and as I said, in this EKG, 2, 3, and AVF show an old inferior MI. Another example, here we see again Q waves in leads 2, 3, and AVF. This is an old inferior MI. Notice the green boxes showing you the Q waves. There are abnormally inverted T waves there as well, and also notice inverted T waves out in V3, 4, 5, and 6. So this tells you that there's some lateral anterior involvement. This may very well be a circumflex infarct, because the circumflex can give you both supply to the posterior wall and also to the lateral wall. Q waves in these leads imply that the MI was not just on the back of the heart, but also involves possibly some of the anterior and lateral wall. Here's another example. Here's a Q waves in leads V1, V2, V3. Notice the green boxes. There's a small residual amount of ST elevation in these leads. So this infarct may have been within the last few weeks or days. And there are also inverted T waves in the rest of the anterior leads. Again, telling you this is an anterior wall myocardial infarct. The computer frequently will read these findings as anterior infarct, age indeterminate. We don't know when exactly it occurred. It's not acute. It's not just occurring right now. It occurred at some point in the past. So just to take a look at what happens to T-wave changes with time when there's an acute infarct. Notice the first complex is normal. See, nice upright T-wave. As the infarct first starts, if you're lucky enough to see the patient within the first few minutes because they happen to be coming into the office or visiting the hospital when they started to have chest pain, the T-wave can go up and can become quite large compared to its baseline. Then ST elevation develops. Then in the next one, you get some T-wave inversion, and notice also that the Q wave has developed now in the fourth complex. In the fifth complex, as time goes on, the Q wave remains, but the ST elevation improves, and then finally, well out, the T wave has normalized, but notice the Q wave has not gone away. The electric hole in the heart remains. There's a scar in the heart that shows you there was a previous myocardial infarct. ST segment elevation may persist for a number of days after an acute MI, and the T-wave inversion may persist for a long time, even years, although usually they normalize within a year or so, but the Q waves may persist forever. If the patient develops a new right or left bundle branch block after an MI, it's a large MI and has a poor prognosis. So we haven't talked about bundle branch blocks yet. That's going to be a whole lecture unto itself. It's when there's been injury to the bundles down in the ventricle, the electrical conduction bundles, the right and the left bundle. When there's injury to that, it usually implies a very large heart attack and has a very bad prognosis. And if there's ST elevation in more than one zone, for example, you're seeing both anterior and inferior, you have to think, oh, maybe this is not a heart attack at all. This could be pericarditis. And I'm going to show you an example where there's ST elevation throughout the EKG, and the real thing that's going on here is pericarditis. It's not an acute MI. By the way, don't use monitor leads to look at the ST segment because they change with the patient's position. So you can mimic ST elevation by rolling around in bed. So don't worry about monitor leads showing ST elevation or ST depression. So let's talk about pericarditis. Here's an example. Notice there's diffuse ST segment elevation and there's no reciprocal changes. Remember, the mirror image changes are not here. There's ST elevation in lead 1, lead 2, lead 3, also in AVF, also in V2, V3, V4, 5, and 6. So there's diffuse ST segment elevation. What's the conclusion? This is not an ST elevation MI. This is pericarditis. And usually the clinical story will tell you too. The patient with an MI, when they take a deep breath, the pain doesn't get worse. When the patient has pericarditis, the pain gets worse. And also pericarditis can occur in young people who are not at risk for a heart attack. They don't have risk factors for atherosclerosis. Computer EKG, I have to emphasize again, is not perfectly accurate. It has to be overread by an experienced electrocardiographer. And what's the best way to become an expert at reading EKGs? Practice. It's just like a musical instrument. You'll get better with time. Now, let's talk a little bit about the immediate changes in the T waves that can occur, which are not an acute MI. So, normal T waves, as you know, are upright in leads V3 through V6 and also upright in lead 1 and 2. They're usually inverted in AVR because remember, AVR is looking from way up here on the right arm, and they can be variable in other leads. If they're inverted, consider a number of things. First of all, some normals can have inverted T waves. It may mean nothing in a perfectly young and healthy person. On the other hand, ischemia or a non-ST elevation MI, we've already talked about, can invert the T waves. Certain hypertrophy patterns, that is, patients with left ventricular hypertrophy from aortic stenosis or long-standing hypertension or hypertrophic cardiomyopathy can have deeply inverted T waves and usually very tall R waves telling you there's lots of heart muscle there. We're going to have a whole lecture on hypertrophy patterns. Interestingly enough, stroke can cause an inversion of the T waves and usually markedly prolongs the QT interval as well. It's thought to be due to damages or pressure on the autonomic nervous system due to the stroke. And of course, metabolic abnormalities, hypokalemia, hyponatremia, acidosis, hypoxemia, all of these can cause T-wave inversions. So just to take a look at what happens to T-wave changes with time when there's an acute infarct. Notice the first complex is normal. See, nice upright T-wave. As the infarct first starts, if you're lucky enough to see the patient within the first few minutes because they happen to be coming into the office or visiting the hospital when they started to have chest pain, the T-wave can go up and can become quite large compared to its baseline. Then ST elevation develops. Then in the next one, you get some T-wave inversion, and notice also that the Q wave has developed now in the fourth complex. In the fifth complex, as time goes on, the Q wave remains, but the ST elevation improves, and then finally, well out, the T wave has normalized, but notice the Q wave has not gone away. The electric hole in the heart remains. There's a scar in the heart that shows you there was a previous myocardial infarct. ST segment elevation may persist for a number of days after an acute MI, and the T-wave inversion may persist for a long time, even years, although usually they normalize within a year or so, but the Q waves may persist forever. If the patient develops a new right or left bundle branch block after an MI, it's a large MI and has a poor prognosis. So we haven't talked about bundle branch blocks yet. That's going to be a whole lecture unto itself. It's when there's been injury to the bundles down in the ventricle, the electrical conduction bundles, the right and the left bundle. When there's injury to that, it usually implies a very large heart attack and has a very bad prognosis. And if there's ST elevation in more than one zone, for example, you're seeing both anterior and inferior, you have to think, oh, maybe this is not a heart attack at all. This could be pericarditis. And I'm going to show you an example where there's ST elevation throughout the EKG, and the real thing that's going on here is pericarditis. It's not an acute MI. By the way, don't use monitor leads to look at the ST segment because they change with the patient's position. So you can mimic ST elevation by rolling around in bed. So don't worry about monitor leads showing ST elevation or ST depression. So let's talk about pericarditis. Here's an example. Notice there's diffuse ST segment elevation and there's no reciprocal changes. Remember, the mirror image changes are not here. There's ST elevation in lead 1, lead 2, lead 3, also in AVF, also in V2, V3, V4, 5, and 6. So there's diffuse ST segment elevation. What's the conclusion? This is not an ST elevation MI. This is pericarditis. And usually the clinical story will tell you too. The patient with an MI, when they take a deep breath, the pain doesn't get worse. When the patient has pericarditis, the pain gets worse. And also pericarditis can occur in young people who are not at risk for a heart attack. They don't have risk factors for atherosclerosis. Computer EKG, I have to emphasize again, is not perfectly accurate. It has to be overread by an experienced electrocardiographer. And what's the best way to become an expert at reading EKGs? Practice. It's just like a musical instrument. You'll get better with time. Now, let's talk a little bit about the immediate changes in the T waves that can occur, which are not an acute MI. So, normal T waves, as you know, are upright in leads V3 through V6 and also upright in lead 1 and 2. They're usually inverted in AVR because remember, AVR is looking from way up here on the right arm, and they can be variable in other leads. If they're inverted, consider a number of things. First of all, some normals can have inverted T waves. It may mean nothing in a perfectly young and healthy person. On the other hand, ischemia or a non-ST elevation MI, we've already talked about, can invert the T waves. Certain hypertrophy patterns, that is, patients with left ventricular hypertrophy from aortic stenosis or long-standing hypertension or hypertrophic cardiomyopathy, can have deeply inverted T waves and usually very tall R waves, telling you there's lots of heart muscle there. We're going to have a whole lecture on hypertrophy patterns. Interestingly enough, stroke can cause an inversion of the T waves and usually markedly prolongs the QT interval as well. It's thought to be due to damages or pressure on the autonomic nervous system due to the stroke. And of course, metabolic abnormalities, hypokalemia, hyponatremia, acidosis, hypoxemia, all of these can cause T-wave inversions. Well, let's do a couple of cases just to give you an example of acute MIs with the story and with the EKG. A 67-year-old diabetic man with a history of elevated blood cholesterol and hypertension comes to the hospital complaining of feelings of indigestion in his upper abdomen and lower chest. He's sweating, he has a low blood pressure, 96/60, and his heart rate is 52 beats per minute. What's important here? Diabetic, higher risk for atherosclerosis. Elevated cholesterol and hypertension, higher risk for atherosclerosis and heart disease. He has discomfort in his upper abdomen and lower chest. Could be a myocardial infarct. And then, of course, he's a little bit hypotensive and he's bradycardic. Okay, here's his EKG. Look at it for a few moments and see if you see anything abnormal. So, there's ST elevation in leads 2, 3, and AVF, and reciprocal changes in 1 and AVL, and this is an acute inferior myocardial infarction. By the way, it's not uncommon for acute inferior myocardial infarcts to depress the blood pressure a bit and the heart rate, usually because of vagal activation that's involved in inferior MIs. So the slow heart rate and the low blood pressure are very commonly seen in inferior MIs, and usually they get better as the MI gets better. What's interesting, if the patient goes to the cath lab and you open up usually the right coronary artery, the low blood pressure and the low heart rate disappear immediately. So we give him evidence-based medications. Angioplasty is performed on the occluded right coronary artery. He does well, goes home in 2 days with an appointment to follow up with his cardiologist. Let's look at a second case. 17-year-old student comes to the hospital complaining of pressure feeling under his sternum, under the breastbone. It's been going on for 2 hours, gets worse when he takes a deep breath, and his physical exam is normal for a 17-year-old. What's important here, long-lasting precordial discomfort, and it worsens with inspiration, so-called pleuritic chest pain. And here's his EKG. Take a look at it for a moment and see if you see a STEMI here, an ST elevation MI. Of course, this is the EKG with diffuse ST elevation. ST elevation in lead 1, in 2, and 3, and AVL, and AVF, and V1, V2, and V3. And even further out, even V4 and 5 also have ST elevation. So diffuse ST segment elevation, what's the diagnosis? It's pericarditis. There's no reciprocal changes, there's no reciprocal depression, and STEMIs don't affect all the leads like this. We do an echocardiogram. Oh, there's a little bit of fluid around the heart, pericardial effusion. So this is pericarditis, almost certainly viral. And the good news is it's usually treated with colchicine and a non-steroidal such as ibuprofen. 2 weeks later, the patient has no symptom, he's active again, he doesn't have any recurrence, and he does very well. We see this all the time. It's a very common thing, viral pericarditis. Welcome back. Today we're going to talk about hypertrophy, that is, growth in muscle mass patterns. It turns out that these carry important clinical implications in the electrocardiogram, and we can recognize right ventricular hypertrophy and left ventricular hypertrophy with the electrocardiogram. Now, the electrocardiogram is not quite as accurate as an MRI or an echo at recognizing these hypertrophy patterns, but when they're present, they usually mean that it's quite severe and it carries major clinical implications. We're going to talk about atrial dilation, and we're going to talk about ventricular hypertrophy. So Everybody knows that the left ventricle has more muscle mass than the right ventricle, and therefore it dominates the electrical activity of the ECG. A left ventricular muscle mass, as it increases, the R wave voltage increases, reflecting this greater amount of LV muscle mass. So think about it for a moment. You have bigger myocardial cells in the left ventricle, therefore there's more electrical activity, therefore the R wave voltage in the leads that reflect the left ventricle get greater. We're going to see some examples in a moment. Here are the ECG changes that occur with left ventricular hypertrophy, often called LVH. Tall R waves, as I've just said. The leads opposite the R waves are going to have deep S waves. Often the QRS is slightly widened, in other words, more than 0.10 seconds. Often there's left axis deviation, that is, the overall electrical activity of the ventricle may be minus 45 or even minus 60. Often there can be STT changes. When there are STT changes with LVH, it means it's more severe and that carries a poorer prognosis. And often we see left atrial enlargement because as the left ventricle hypertrophies, the filling pressure in the left ventricle goes up, resulting in dilation of the left atrium. This is an example of left ventricular hypertrophy. Notice, first of all, that the R wave in lead 1 is very tall, in this case more than 13 millimeters. Notice that the S wave in V1, V2 is very deep, and the R wave is very tall in leads 4, 5, and 6. In fact, there are a number of formulas that lead to the diagnosis by electrocardiogram of LVH, but in fact one of them is the S wave in V1, V2 plus the R wave in V5, V6 greater than 35 millimeters if the patient is over age 30. And certainly if you add this up, you'll see it's many more than 35. It looks like about 20 and 20, so 40. Another pattern that's been associated with left ventricular hypertrophy is the R wave in AVL and the S wave in V3. In this case, should be greater than 20 in a female or greater than 28 in a male. In this case, it doesn't quite make it. The computer has about 5 or 6 different algorithms for LVH. So the computer will read LVH when you're looking at it and you're saying, gee, it doesn't look like LVH. However, none of these is perfectly accurate, but they do carry some clinical significance. When LVH is seen on the ECG, it's usually not a good sign. It means that there's a presence of organic heart disease. And here's another example of LVH. Notice the high voltage in lead 1, tall R wave, just like we talked about. And then notice again in V1 through V6, very deep S waves in V1, V2, very high R wave in V5. And remember, if you added up the S wave in V1 to the R wave in V5, it's going to be many, many more millimeters than 35. You'll also notice the inverted P waves in lead V1 with the final component, the the depressed component of the P wave. You'll notice it's usually wider than 1 box and deeper than 1 box. That's left atrial enlargement. And in many of the LVH formulas, that adds points to confirm the diagnosis of LVH. So here we see another example. Look at lead V2. It has 5, 10, 15, 18 millimeters. Now look at V5. 5, 10, 15, 20, 25, 30, 35. So 35 and 18 is a lot more than 35 total. So you've got, in this case, they saw 19 plus 35, 54, greater than 35. This is very suggestive of LVH. Notice also that the T wave is inverted in lead V5. When that's associated, it usually means more marked LVH and a worse prognosis. Here, look at this change. Consider what you're seeing. Tell me in your mind what you're seeing. What I'm seeing is very large R waves in V5 and 6 with very deep S waves in V1, V2, V3. Again, adding them up, you're going to have an LVH. Notice you also have downsloping ST segment and inverted T waves. Again, as I mentioned, this is a finding that says more severe LVH and a poorer prognosis. What about this ECG? Note large voltage in lead 1, large voltage in V3, large S-wave voltage in lead 3, large R-wave voltage in lead AVL. Again, this is left ventricular hypertrophy. Lots of muscle mass in the left ventricle. So what about right ventricular hypertrophy? Well, right ventricular hypertrophy, remember, we talked about this in the first lecture. The right precordial V1 electrode is very much over the right ventricle because the right ventricle is right under the sternum. So right ventricular hypertrophy is usually shown by an increase in the R wave in lead V1. Remember, we talked about in LVH, the increased R wave voltage is in V5-6. But here, with right ventricular hypertrophy, the increased voltage is in lead V1. And of course, the right ventricle almost always has less muscle mass compared with the left ventricle, so the R wave is not as impressive. The increased R wave in V1, not as impressive as the increased R wave in V5 and 6. And we'll look at some examples in a moment. So here are all of the kinds of changes you can see with RVH. First of all, taller R wave in V1. Normally, a patient who has a normal cardiogram won't have an R wave more than 1 or 2 millimeters in V1. If it's fairly big, and particularly if it's bigger than the S wave, that suggests right ventricular hypertrophy. There are often deep S waves in the lateral leads, that is leads 1 and AVL, also reflecting the increased RV voltage. And often there's a right axis deviation greater than 90 degrees. So the axis deviation is going somewhere down this way. And often there is a tall peaked P wave greater than 2 millimeters. That's right atrial enlargement. So just as left atrial enlargement accompanies LVH, right atrial enlargement accompanies RVH. And here are some examples. First of all, notice how tall the R wave is in the green box in lead V1. This is actually a patient with pulmonic stenosis that leads to very significant increase in right ventricular mass and therefore large R wave in V1. Notice the deep S wave in lead AVL that we mentioned before, again reflecting RV hypertrophy. You'll notice that there's right axis deviation. Look, the maximum R wave in this case is in AVR. It's somewhere way up here. So that's a huge right axis. That's a right axis deviation all the way around to here. And you can see that there's almost no R wave in lead 1, 2, and 3 is perpendicular, right? So it's probably 90 degrees from 120 or plus 210, which is AVR, and that's where the maximum R wave is. And then notice the tall P waves in the little black box. These tall spiked P waves are right atrial enlargement, and you can also see them in lead V2 and V3. So here's another example, tall R waves in the green box in lead V1, and notice tall P wave, very tall spiky P waves in leads 2 and in lead V2. Again, right atrial enlargement and right ventricular hypertrophy. Again, another example, notice the tall R wave in lead V1, and you'll notice there's a widened QRS out in the precordial leads out at V6 with a big deep S wave. That's reflecting the big R wave in lead V1. Again, an example of right ventricular hypertrophy. And there's also, again, look at the limb leads. There's right axis deviation. The maximum R wave voltage here is between leads 3 and AVR. So it's something like 180 plus. So right axis deviation, increased R wave in lead V1, and a big broad S wave in V6, right ventricular hypertrophy. So Here we see a patient with both left ventricular hypertrophy and right ventricular hypertrophy. Let's look at the findings. First of all, look at the voltages in leads V4, 5, and 6. You'll see pretty much very high voltages there that also are reflected in the limb leads. Look at the tall voltages in 3. You also notice, though, that it's a predominant R wave in V1. So wait a minute, this is looking like there's both left ventricular hypertrophy and right ventricular hypertrophy. So you notice lots of volts over the left precordial leads and lots of voltage over the S1, the tall R wave. So this suggests that there's both right ventricular hypertrophy and left ventricular hypertrophy. If you also look in the green box that's showing you lead 1 and 2, notice the tall spiky P waves, right atrial enlargement. So again, we're dealing with a patient here that has both left ventricular and right ventricular hypertrophy. Not seen very commonly, but definitely there. And here we show you again the right atrial enlargement in the black box. So let's just talk about right and left atrial enlargement by themselves. Just to review, we've talked about this before. Here's the normal P wave, right? It's 3 boxes in duration or less, not wider than that. It's upright in leads 1 and 2 and doesn't have a big negative deflection, for example, in V1. In V1, you'll see in a moment the big negative deflection that suggests left atrial enlargement. So here we see a very nice example, spiky, tall, and broad P wave in lead 2, right atrial enlargement. In this case, it's 2.5 millimeters in height, and in V1, it's upright. It's not inverted as here in left atrial enlargement. Look at the secondary component of the P wave. You notice how inverted and deep it is. That's left atrial enlargement. And you can see it. The length of the P wave is also prolonged, more than 3 little boxes, so it's more than 120 milliseconds. And there's the downward deflection of greater than 40 milliseconds and 1 millimeter wide. Big, deep, inverted secondary component to V1 suggests left atrial enlargement. Here we see another form of left atrial enlargement. This is often seen with mitral stenosis. You'll notice the big, broad P wave and the double hump on it spelling the letter M. So it says mitral valve disease, mitral stenosis. And over in V1, again, you see a prolonged, deep, inverted secondary component. Both of these suggesting left atrial enlargement. Tall P waves higher than 2 little boxes. Notice in AVL in green, this suggests right atrial enlargement. So let's do some cases. A 52-year-old man comes to the emergency department complaining of shortness of breath whenever he walks. He says he was once told he had high blood pressure, but he didn't particularly like his doctor, so he never did anything about it. His physical exam shows very impressive high blood pressure, 190 over 108. His heart rate's quite fast at 96. And the rest of his physical exam shows signs of early heart failure. He might have crackles at the base, his JVP, his jugular venous pulse might be elevated. So there's some heart failure, and it's almost certainly due to untreated high blood pressure. So the clues here, he has dyspnea, shortness of breath. He has nasty untreated hypertension. And sounds like there's some heart failure involved here, probably from untreated hypertension. And here's his cardiogram. Take a look at it for a few minutes and see if you can identify the abnormalities. So, notice, first of all, big, tall R wave in lead 1. Notice deep S waves in the precordial leads V1, V2, V3. And you'll notice also abnormal ST segments. And there's also increased voltage in V4 and V5. All of this together says left ventricular hypertrophy with ST changes. This suggests, in fact, quite severe left ventricular hypertrophy. The diagnosis is left ventricular hypertrophy. You'll notice also that the T waves are inverted in leads V5 and V6, also part of this left ventricular hypertrophy with ST and T wave changes. Here's a 44-year-old woman visits her doctor, and she's complaining of increasing shortness of breath and fatigue over the last year. She was well before that, never had rheumatic fever that she knew about, and her physical exam reveals a loud pulmonic component of her second heart sound, as well as swelling of her lower legs. So, the normal second heart sound is lup-de-dup, lup-de-dup, lup-de-dup. But you know, if you hear the second component very loud, particularly at the apex, lup-de-dup, 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 that suggests increased pressure in the pulmonary circulation. And those of you who have looked at the lectures in cardiology have seen that finding emphasized at that time. Patient has dyspnea. There's a sign of pulmonary hypertension with the loud pulmonic sound, and she has peripheral edema suggesting some heart failure. And here is the cardiogram. Take a look at it for a few minutes. What are we seeing? First of all, tall R waves in lead V1. Secondly, deep S waves in lead AVL. That's in the red box. And also look at the blue box. It's showing you right atrial hypertrophy, spiky right atrial hypertrophy P wave pattern. So the diagnosis is right ventricular hypertrophy, and it's secondary to pulmonary hypertension. Thanks very much for participating in this lecture, and we look forward to talking some more about EKG patterns with you. Welcome back to the ECG lecture series. Today we're going to talk about bundle branch blocks. So bundle branch blocks are when the normal QRS width is greater than 0.10 seconds. And the wide QRS means that there's slowed electrical conduction through the ventricles. So let's review the conduction system again. Remember this from the very first lecture. Let's look at it again in its normal state, and then we can talk about the abnormal state. So here's the little diagram that we saw before. Remember that the impulse starts in the sinoatrial node that depolarizes automatically and sets off the electrical wave that passes down through the atria to the atrioventricular node where there's a pause, right? And the pause is to allow the atrium to empty before ventricular contraction starts. Then the impulse travels down through a common bundle called the his Purkinje and then splits into a right bundle and a left bundle. The left bundle has two branches, an anterior fascicle or branch and a posterior fascicle or branch. So this is the electrical conduction system in the heart. So remember that each myocardial cell has an electrical activity which leads to the ventricular or the atrial contraction. So it's electrical impulse followed by mechanical impulse. There's, in the action potential, an initial upstroke. There's early fast depolarization followed by a plateau, and then the cell resets itself, ready for the next beat, and then rests for a moment in diastole, and then starts again with the rapid upstroke and so forth. And as the wave passes through the myocardium, each cell goes through this action potential. There are special cells in the right bundle and the two branches of the left bundle that enable the electrical activity to pass more rapidly into the ventricular muscle. And of course, once the electrical activity gets into the muscle, it triggers the contraction. So you have the electrical wave coming to the heart muscle, and that's followed by a myocardial cell contraction. In a sense, the electrical wave is the trigger that sets off the mechanical myocardial cell contraction. Remember again, we've just gone over this. You start with the sinus node, the pacemaker, that has this funny channel that leaks sodium ions causing the cell to spontaneously depolarize and initiate the wave of electrical activity in the heart. That starts the electrical wave of activity. It passes through small pathways in the atrium, then gets to the AV node where there's the delay, gets into the bundle of His, also called the His-Purkinje bundle, then goes down into the right and left bundle branches and gets out into the small fibers of the Purkinje system throughout the ventricles, and that coordinates the contraction of atria and ventricles. And you'll remember this, we've gone over this before. And so here you see the wave passing into the ventricle, down through the septum, and then it hits the apex and then starts to go back up towards the atria and then concludes. And so you see that the wave is moving in a sense, when seen by the electrodes, in two different directions, and that causes sometimes when it moves towards the electrode, there's an upward deflection of the EKG. When it's moving away from the electrode, there's a downward deflection, as we've talked about in the first lecture. That the ventricular depolarization in the intact heart generates a changing electrical field and the changing QRS, depending upon the electrode is seeing the impulse coming towards it or seeing the impulse going away from it. And the membrane resets during the T wave phase and is ready for the next electrical wave. And so when there are damages to the elements of the conduction system, they delay atrial or ventricular contraction, and these damage to the elements of the conduction system can lead to either sick sinus syndrome, an abnormality in the sinus node, or it can lead to abnormalities in the ventricular system, which is seen as bundle branch block. Let's look first at the damaged sinus node. The failure of the node to start the electrical wave markedly slows the heart rate or causes a delayed heartbeat, and abnormal sinus node function is quite common in elderly patients, and it's called sick sinus syndrome. And it's often associated with periods of very slow heart rate, followed by arrhythmias, where the heart rate's very fast, and it's often treated with pacemaker, and we're going to talk about that later when we talk about arrhythmias. What about the bundle branch block? Abnormalities in the right or left bundle branches lead to a widened QRS, so greater than 0.10, and a QRS of 0.11 is sort of a non-specific conduction delay, but when it's 0.12 or more, it's called a bundle branch block, either right or left. So let's look first at right bundle branch block. Here is a typical right bundle branch block pattern. First of all, deep S wave in lead V1. Why? Because there's late depolarization of the right ventricle and parts of the septum that are supplied by the right bundle. And there's also deep S waves in V6, again showing late slowed depolarization in the areas of the right bundle. In addition, there's the famous so-called rabbit ears in lead V1. There's two upward deflections. In other words, there's an R and an S, and then the so-called R prime, or a second R, so-called rabbit ears. And the rabbit ears can be a very different size. I'll show you an example where there was a little tiny initial rabbit ear and a big second one, and I'll show you examples where both rabbit ears are of equal size. Notice again in V1, the deep S waves. Notice also, look down in V6, there are deep S waves. So this is and the right bundle is reflected in a QRS duration of 0.14 seconds, greater than 0.12. So this is a typical right bundle branch block. Here's another right bundle branch block. Notice the rabbit ears. Notice that the first rabbit ear in lead V1 is pretty small, and even in V2, and the second rabbit ear is quite big. But again, the duration of the QRS is 0.14 seconds. And you'll notice also a big broad S wave in lead V6. See the rabbit ears? And the deep S wave in V6. And here the QRS duration is even longer than 0.14, it's 0.16. Here's another, this is a more typical example of rabbit ears. You see both rabbit ears are about the same size. It's a wide QRS. Notice there's also in lead V6 and lead 1 a wide S wave. Here, the rabbit ears are much more typical, and the QRS duration here is 0.14 seconds. And here's another example of a bundle branch block. Is this a right bundle or not? Look at it for a moment and think about it. Do you see rabbit ears? I don't see any rabbit ears. In fact, what you see, a wide QRS, 0.14 seconds, big upright R wave in lead 1, and a big broad upright R wave in lead V6, and broad S waves in lead V1, V2, V3. So this is an example of left bundle branch block. Wide QRS in all the leads. Again, the upright broad pattern in lead 1 and V6, and there's often ST abnormalities, marked ST elevation. So this EKG is sometimes mistaken for an acute MI, but you got to look at the width of the QRS. If it's greater than 0.12, it's a left bundle, and you can't read a myocardial infarct with left bundle branch block. Now here's one where the QRS duration is only 0.11. So it's a little bit left bundle-ish, right? Look at lead 1 and lead V6. There's no rabbit ears. So often this is called a non-specific ventricular conduction delay. So there's a block in part of the left bundle, but it really isn't enough to be called a left bundle or a right bundle. Now you can see blocks in part of the left or right bundle, left bundle rather. You can see blocks in the anterior portion of the left bundle or in the posterior. Let's look at these. Let's look at the first one. There's the block in the anterior portion of the left bundle, sometimes called the left anterior hemiblock or half block, or the left anterior fascicular block. First thing you see when you knock out the left anterior half of the left bundle is there's a marked axis deviation to more than 45 degrees. So minus 45 or minus 60, so up this direction. You see a small Q wave in AVL. And it can't be diagnosed when there's an inferior wall myocardial infarction, because that often results in a marked left axis. So that takes away the criteria for a left anterior hemiblock. The left anterior hemiblock is quite common, and it doesn't imply serious heart disease. It's only a little bit of the left bundle that's blocked. Here's a typical example. You can see marked left axis deviation. Notice that the tallest R wave here is in lead AVL, so that the left axis is minus 60. There's a widened QRS, generally 0.11, something like that, and there's a small Q in lead AVL. So left anterior hemiblock. Block in the posterior portion of the left bundle is more serious. Why? The left anterior branch is very small and thin, and it can easily be damaged by scarring or hypertrophy of the ventricles and so forth as people age. The left posterior bundle is huge and broad, so when it's damaged leading to left posterior hemiblock, it usually means there's a lot of injury to the ventricle. So let's look at the posterior hemiblock characteristic. Notice, first of all, the frontal plane axis goes in the opposite direction, right? Remember, left anterior hemiblock was minus 60, 45 to 60, but left posterior hemiblock is plus 90 to 180, and the QRS is still not more than 0.12, because if it was more than 0.12, it would be full left bundle branch block. It's uncommon due to the broad nature of the posterior bundle, as I said, and it also has a dual blood supply, so it usually survives even when the left anterior bundle is knocked out. And here we see an example. Notice leads in the green box, leads 3 and AVF are the maximum R wave. Remember, lead 3 is plus 120, lead AVF is plus 90, so it's somewhere between 90 and 120. So in this case, the computer has calculated as plus 100. You'll notice that the QRS is not wide enough to be a left bundle branch block. So left anterior fascicular block is common, not due to severe damage to the conduction system. left posterior fascicular block, uncommon and due to important damage to the conduction system. Left bundle branch block almost always occurs in association with one or another form of serious heart disease, for example, cardiomyopathy. So left anterior fascicular block can be just an aging change. Left posterior and left bundle usually imply more serious heart disease, for example, previous myocardial infarction or cardiomyopathy. All right, let's do a case. A 70-year-old man suffers an acute anterior myocardial infarct. He has heart failure. There's crackles in the lungs from fluid. He's hypotensive, low blood pressure, tachycardia, fast heart rate. Jugular venous pressure is elevated, implying that right atrial pressure is elevated. And on the second post-MI day, we record the following ECG. Okay, so what is this pattern? Note the wide QRS in all leads. Do you see rabbit ears? I don't see any rabbit ears. Notice the marked ST segment changes here. And there's no MI pattern. You know, there's no Q waves. This is left bundle branch block. Left bundle branch block shortly after MI is a bad sign. Remember we talked about it means extensive damage, means a large infarct, and these patients need to very, very quickly go to the catheterization laboratory and have usually the left anterior descending coronary artery opened up. Now, you can have other combinations of bundles. So you can have a patient that has a previous left bundle, now develops a right bundle. That, as you will see in a moment, leads to complete heart block and a very slow heart rate, and we're going to have a whole lecture about that as we go along. You can have either a left bundle and a right bundle with left anterior fascicular block, so right bundle, rabbit ears, plus marked left axis deviation. Or you can have a left bundle with, again, marked left axis deviation. You can also have left or right bundle with a left posterior block with marked rightward axis deviation. And you can see that these are all high risk because the conduction system has been severely damaged, that they're high risk for complete heart block. Very low heart rate often seen, low blood pressure, and if and when complete heart block develops, patients need pacemaker therapy. So, thanks very much for watching this video, and I look forward to speaking with you some more about abnormalities on the electrocardiogram. Hello, and welcome back to the EKG course, or ECG course, depending upon which abbreviation you prefer. Today we're going to talk about electrical blocks in the electrical system of the heart that can be benign or it can be life-threatening. And I will take you through the whole spectrum of heart blocks from minor to much more severe. So when heart block occurs, there is a malfunction in the electrical system, leading usually to a dropped or missed beat on the ECG or multiple dropped or missed beats. So let's start in the first area, in the sinus node. I mentioned in one of the last lectures that the sinus node can be diseased, just like the rest of the conduction system can be diseased. And when that happens, often beats fail to emerge from the sinus node, and often that's called sick sinus syndrome, SSS. And in that situation, you may have at times very slow action by the sinus node, and intermittently one may have breakaway rapid arrhythmias, and it's called bradykardia. The word bradycardia means slow heart rate, and the word tachycardia means fast heart rate. And often that's treated with drugs and with a pacemaker. Now, what happens when the blockage in the cardiac electrical system is lower down? So if it's in the sinus node, this can be a minor problem, or you can have the Brady-Tachy syndrome where you need drugs and a pacemaker. But usually most blocks are not so much in the sinus node, but they're lower down in the AV node. And when the disease in the AV node becomes severe, beats may not get through to the ventricle. You may have a very slow heart rate, and again, pacemaker therapy may be required. And we're going to go over that in more detail. Sometimes the block is even below the AV node, and that can result also in very severe slow heart rates because no impulses are getting through to the ventricle. So heart block below the AV node, as I said, often results in a very slow heart rate and requires a pacemaker therapy. Sometimes these patients will have heart rates as low as 20, and of course that results in a very low blood pressure, and people can faint, and eventually, if you don't put a pacemaker in, it will be fatal. So let's start with some examples. We'll start with the sinus node. So here's an example of a sinus node block. Let's follow through the rhythm strip. The first complex has a P wave, a QRS, and a T wave. The next complex has a P wave, a QRS, and a T wave, and then in the area of the green box, we're missing a P wave, and then the rhythm resets again. You'll notice when it resets that the P wave in the resetting first beat after the green box is slightly abnormal, which means the impulse is coming either slightly to the right or left of the sinus node or nearby, or else emerges abnormally from the sinus node, but then it resets itself normally. You'll see the last complex, P, Q, R, S, and T, is just like the beginning ones. Now, so the P wave was absent due to an abnormal sinus node function. And in this case, we call it a sinus exit block. That is, the electrical impulse failed to come out of the sinus node. And usually an occasional single drop beat like this is not symptomatic and is not serious, except it warns the clinician that the patient has abnormalities in sinus node function. I point out that the unusually shaped P wave on the next beat after the green box, the one in the black box, is an atrial escape beat. It's not directly from the sinus node, or it's emerging abnormally from the sinus node, which is why it looks a little different from the other P waves. Eventually, the sinus node resets itself, and subsequent P waves in the rhythm are normal. Now, again, as I mentioned before, sinus node dysfunction is much less common than atrioventricular node dysfunction. So the interruption in the electrical conduction system usually occurs in or near the AV node, and there are three levels of block. One is benign or relatively benign, one is more serious, and one is very serious. And we call them first degree AV block, second degree AV block, and third degree or complete heart block. And we'll talk about each of these now in more detail. So here we see first degree AV block. And you can see, look on the top strip, there is a you can hardly see the first P wave, but let's look at the second beat. There's a P wave, then there's a QRS, but look at how long the pause is between the P wave and the QRS, and the next beat as well. It's taking a long time for the electrical impulse to get through the AV node. So remember that the normal PR interval is 0.2 seconds, or 5 little boxes. In this case, the PR interval is actually 9.5 little boxes, or 0.38 seconds, and we call this first degree AV block, usually asymptomatic. The patients don't notice it. Here is another example of first degree AV block. You'll notice, again, normal PR intervals are 3 to 5 little boxes, 0.12 to 0.20 seconds. In this case, it's 6.5 little boxes, or 0.26 seconds. In other words, first degree AV block. Another example, not as severe as the last one. Let's move on and talk about second degree AV block. Second degree AV block is more serious in that there are dropped beats. There are two types of second degree AV block. There's type 1 and type 2. Type 1 is often called Wenckebach block or Mobitz type 1 AV block, and you'll see there's a Mobitz type 2 AV block. Both of these are second degree AV block. And Wenckebach and Mobitz were physicians who studied electrical activity in the early days of the electrocardiogram. What happens with type 1 second degree AV block, or Wenckebach or Mobitz 1, it's characterized by a progressive increase in the PR interval. And eventually, there's a missing QRS. The interval gets so long that the impulse doesn't get through to the ventricle, and you drop a beat. And the sequence repeats itself. Now, usually it's 3 to 5 beats and a drop beats. For example, 3 beats and the 4th beat is missing, and again 3 beats and the 4th beat is missing, and so forth. Could be up to 5 beats and the 6th one is missing. And you'll see increasing PR intervals. I'm going to show you that. And of course, the last P wave is not followed by a QRS. So type 1 second-degree AV block occurs when the impulse travels down from the sinus node through the atrium and arrives at the AV node. And there's a pause before it gets through into the main His-Purkinje system and into the ventricle. And of course the left bundle and the right bundle and the Purkinje fibers in the ventricle. So the block occurs higher up in the AV node, and therefore the impulse doesn't get through to the ventricles, to the right and left bundles and so forth. So the block of the electrical transmission occurs just above or in the upper portion of the AV node. And you can see the little green box showing where that is. Now, here's an example. Notice, this is a Wenck block. 3 impulses get through with lengthening PR interval, and the 4th one is blocked. Let's take it one sequence at a time. The first one, with the first green box, shows you a normal P wave with a normal PR interval. Then there's a QRS and a T. The next P is normal looking, but look, the PR interval has lengthened, the second green box, followed by QRS and T. Now look at the third. Oh, the PR interval is even longer. QRS and then T. Then comes a P wave. Uh-oh, we're missing the QRS. And then eventually it resets itself and starts again. So this is 3 to 4. That is 3 impulses get through to 4 atrial impulses. And you can see the increasing PR interval. So this is type 1 second-degree AV block. And as it says here, the 4th PR interval is too prolonged to capture the ventricle, and therefore it's missing. And the next P wave starts the whole sequence over again. Now, here is another example of it. And if you stand back and look at this from a distance, you see what's known as group beating. Notice, look at the bottom line, or at the top line, but the bottom line shows you the P wave nicely. You see 4 beats and a drop beat, 4 beats and a drop beat, and so forth. And so when you hold this out at arm's length, you see these groups with pauses, groups of normal beats and a pause, groups of normal beats and a pause. And here, of course, we show you where the missing QRS is. The second type of type 2 AV block is a serious type. It's also called high-grade AV block or Mobitz type 2 AV block. It is lower down in the conduction system, not usually below the AV node. And it consists of P waves that are repeatedly not followed by a QRS, telling you that there's higher grade block below the AV node. It can be 3 to 1, in which you have 3 normal beats followed by a blocked beat after the 4th P wave, or it could be a single blocked beat that is repeated multiple times. And the PR intervals, of course, on the normal beats are normal, and then all of a sudden there's a P wave with no QRS. And that's an example where the 4th beat was blocked, so you had a P wave with no QRS. With 2 to 1 AV block, it may be difficult to tell whether you're seeing type 1 or type 2, and there the electrophysiologist can make measurements, often in the electrophysiology laboratory, and if it's type 2 AV block, they often follow that with pacemaker insertion. So let's look at an example. Here is an example of type 2 second-degree AV block. You'll notice the first complex, P, QRS, and T, normal. Second complex, P, QRS, and T, normal. Third complex, P, QRS, and T. 4th P wave, no QRS. And then it takes over normally again, P, QRS, and T. So this could have been a 2 to 1 type 1 block, but it's very worrisome, and we would have to make sure that it's not a type 2. Why? Because this kind rapidly goes into complete heart block, 3rd degree heart block that could be life-threatening. So the P wave is completely blocked in or below the AV node. It can be frequent with many drop beats, and usually is, so when you get a long rhythm strip, you see what's going on. And again, it implies serious disease in the conduction system, usually requiring pacemaker therapy. Here's another example. You'll notice here we see it twice. There's a normal beat. The first beat is a P, QRS, and T. Then there's a P wave with the green arrow. Oh, no QRS. Then we have a normal beat. Oh, then another P wave, green arrow, no QRS. So here's two complexes that are lacking conduction of the ventricle. And when you take a longer rhythm strip and you see multiples of these, the patient gets almost always a pacemaker because they're very close to third-degree heart block. Just a little information about it. Type 1 AV block, second-degree AV block, can occur in normal, healthy individuals. It's common in well-trained athletes and in young people. It's due to increased vagus nerve activity, which goes with training, and usually it's benign. And when I'm at the university, every year I see some of our super athletes who are training for the Olympics or for national competition, and they're sent over, oh, this person has an irregular heartbeat. And often they have type 1 second-degree AV block and sinus bradycardia because of the training effect. And pacing is definitely not needed. We reassure them this is normal. You put a patient like that on the treadmill, their heart rate accelerates normally. So it's not really disease, it's a training effect. Now, type 2 second-degree AV block is the nasty one. The block of the electrical transmission occurs just below or in a lower portion of the AV node. Here we see the system again. So again, both type 2s are occurring in and around the AV node, but type 1 in the upper portion or just above, type 2 in the lower portion or just below. And type 2 is more serious because it often can lead on to third degree or complete heart block, as we'll talk about. And of course, you see the impulse, once it gets through to the His-Purkinje system, it gets transmitted throughout the ventricle through the left and right bundles and into the ventricular muscle. Now, third-degree heart block is called complete heart block. Complete heart block means the P waves are not ever followed by a QRS that relates to it. In other words, the ventricle has a subsidiary pacemaker that takes over at a very slow rate, and often the patients are very symptomatic. In third-degree AV block, the wave of depolarization from the atria, as I said, is completely blocked, and there's a subordinate pacemaker in the ventricle taking over. There's a markedly slow heart rate. There's a wide QRS, unlike type 1 and type 2, which have narrow QRSs, and they have wide QRSs because the impulse is generated in the ventricle and abnormally transmits through the ventricular myocardium, and there's no relationship between the P waves and the QRS waves. So here's an example of third-degree AV block. Notice we start off with a QRS, then there's a P wave, and there's another P wave. Oh, and here's a QRS. Oh, and look, there's another P wave afterwards. You'll notice these P waves are not in any relationship to the QRS. So in the second complex, you have what could be a normal PR interval. But wait a minute, the next one is long, and then the next one is short. In other words, the P waves are moving at their own rhythm, and the QRS is moving. One way to tell this is to determine the heart rate of the P waves. In this case, the heart rate of the P waves is 75. That's 4 big boxes, whereas the rate of the QRS is much slower. It's about 35 to 40. Let's look at a case of an example of a patient who is having some heart block. So here's the history. We see an 88-year-old man. He suddenly faints while eating dinner. He's immediately attended by a nearby nurse. Ambulance comes and gets him, brings him to the hospital, where his blood pressure is 88/40, quite low, and his heart rate is 36, also quite low. What are the critical factors here in this case? First of all, there's a syncopal episode. He faints. Secondly, he's hypotensive. Third, he's bradycardic, very slow. So here's the EKG. Think about this and come up with a diagnosis. If you came up with the diagnosis of complete heart block, you would be right. How would we know that? Markedly slow heart rate, a wide QRS because of the subsidiary slow pacemaker in the ventricle, no regular relationship between the P waves and the QRSs. If you plot that out, you'll see the P waves are occurring at a faster rate than the ventricle, and they're occurring randomly in relationship to the QRS. So the diagnosis, complete or third-degree heart block. The treatment is a permanent pacemaker, restoring the normal heart rate, restoring the normal blood pressure, and people go on and live many years with permanent pacemakers. Thanks very much for being with me for this lecture. Please stay tuned for the next one. Welcome back to the EKG lecture series. Today we're going to be speaking about supraventricular arrhythmias. So for example, a rapid heart rate greater than 100 beats per minute with the sinus node appearing regular is called sinus tachycardia. And a normal P wave in front of each QRS with a heart rate less than 60 is called sinus bradycardia. Here in the little table, sinus tachycardia, increased heart rate above 100, sinus bradycardia, decreased heart rate below 60. So, these sinus arrhythmias are normal. They happen every day in healthy individuals. For example, if you exercise, you go out to run, or you get on the treadmill, or you're the rowing machine, your body responds by increasing the heart rate because it's increasing the cardiac output to increase blood flow to the muscles. So your heart rate goes over 100. It's perfectly normal. That's what happens with exercise. Sometimes if you get excited because you're seeing an exciting sports event, or you wake up from a nightmare, you're going to have sinus tachycardia. But normally during sleep, the heart slows down because you don't need to pump as much blood to the resting muscles, and often the heart rate is less than 60. In other words, sinus bradycardia. So excitement or exercise can cause sinus tachycardia, sinus bradycardia, for example, during sleep, and both are normal and are frequently present in healthy individuals depending upon the situation: sleep, exercise, excitement, and so forth. So here's an example of a rhythm strip from a patient who was exercising vigorously, and the heart rate is 135 to 140 per minute. And you can calculate that if you want by calculating the big boxes and dividing into 300. It's almost 150, a little less, and therefore this is 135 to 140. Normal sinus tachycardia in an individual exercising vigorously. Here is an example of sinus bradycardia, and this is occurring in a patient who's in deep sleep and the heart rate is 43 per minute. Notice there's a P wave in front of each QRS. The QRSs occur normally. Look at the bottom strip. That's the rhythm strip. You'll notice P, QRS, P, QRS, normal relationship of P to QRS, just a very slow heart rate. Normal in deep sleep. So supraventricular arrhythmias, as I mentioned right at the beginning, occur above the AV node. They occur in the atria. Or sometimes they involve the earliest part of the AV node, but in any case, you're still in the atrial area. And the QRS is usually narrow because it's a beat arising from up top. Remember in the lecture on heart block, when you used a subsidiary pacemaker down in the ventricle, the QRS was wide. But where you're dealing with arrhythmias from above, the QRS is usually narrow unless the patient has a pre-existing bundle branch block. For example, they had a right bundle before they developed this, or sometimes the heart rate goes so fast with a supraventricular, then you may induce a so-called rate-related right bundle, which disappears when the heart rate slows down. And that's what is pointed out here. A fast, very fast heart rate can result in fatigue of the right bundle, and this leads to a right bundle branch block pattern that occurs during the tachycardia, but once the heart rate slows down, you go back to the normal narrow QRS. This happens sometimes in an arrhythmia, which we're going to see in this lecture, called atrial fibrillation, and we'll show you some examples. So let's start with the simplest atrial arrhythmias. These are single atrial premature beats. You can have 1 to 3 of these beats, sometimes in a row. They originate in the atrium. They are extra beats, therefore they're called premature atrial beats. And they are often preceded by an abnormally appearing P wave, but sometimes you can't see the abnormally appearing P wave. It doesn't appear in the lead or the rhythm strip you're looking at. So here is an example of atrial premature beats. Let's look at the first complex. We don't see the P wave there. So let's look at the second QRS. There's a normal T wave. Then you have a normal P wave in the third beat and a T wave. And oh my goodness, look at that. There's a beat that occurs much too early. Now, if you look at the T wave there, you'll note and compare it to the previous T wave, you'll notice it's different. Why? Because there's an abnormal P wave added into that T wave. So compare it to the T wave of the second beat. The T wave from the second beat is a normal T wave, and the T wave of the third beat is a combination of the T wave plus the abnormal P wave from the premature beat. Now, if we look at the fifth beat, that's normal. Normal P, normal QRS, normal, not normal T, an abnormal T, because again, it's the combination of the T wave and the premature beat, and you see the premature beat. Each of these two premature beats are marked with a green arrow, and you can see and subsequently this rhythm continues. Normal beat, premature beat, normal beat, premature beat, normal beat, premature beat, and in each case, the T wave before the premature beat is abnormal because it's a combination of a normal T wave and an abnormal P wave. And that's pointed out here. The second hump on the T wave corresponds to the P wave from the atrial premature beat, and it's partially hidden or combined within the T wave. The QRS of the atrial premature beat is slightly widened because there's a little bit of intraventricular delay caused by the abnormal arrival of the premature beat's electrical impulse. In other words, the system hasn't totally reset itself. So you have a slightly abnormal QRS, but it's still narrow, but not quite as narrow as the normal beat. And that's probably because the whole system below the AV node hasn't had a chance to totally reset itself. So you get a little tiny amount of block there, but still narrow QRS. Now, a sustained run of atrial premature beats is often called supraventricular or atrial tachycardia. It's a tachycardia developing in the atrium or above the ventricle, supraventricular. Often the cause is a so-called recurrent circular depolarization wave that's running around the atrium. And often this is because of little areas of scarring or fibrosis in the atrium. And so you get an impulse that instead of just normally going down the system like this, starts doing this, running around within the atrium and periodically sending beats down through the AV node. So this recurrent circular depolarization wave, it's often called a circus movement. Why? Those of you who have been to the circus know that there are rings down on the ground floor of the circus, and often the horses come in and go around and around and around in the ring. So the circular movement is like the horse going around and around and around in the circle. What happens is this is a so-called re-entrant depolarization. That is, instead of going normally forward, it keeps re-entering within the atrium, around and around and around, and sends periodic beats down through the AV node, usually resulting in a fast rhythm. So here we see a supraventricular tachycardia. This is very nice in that you can see the abnormal P wave. First of all, look at the heart rate. The heart rate is extremely fast, 180 beats per minute, and you can calculate that out. Remember, if there were two big boxes in between those two beats, that would be 150. If there was only one box, that would be 300. So you can see this when you calculate it out with a ruler or doing the math in your head. The heart rate is 180. Notice there's a narrow QRS, and look, first of all, you see the QRS, then there's a T wave, then there's an abnormal P wave, then there's a QRS, then there's a T wave, an abnormal P wave, and a QRS, and so forth. So this is a supraventricular tachycardia, almost certainly due to a circus movement in the atrium. Sometimes the circus movement also involves the upper part of the AV node, and there are many different kinds of circus movements. that's of importance to the cardiac electrophysiologists, that I like to fondly call them the cardiac electricians, because they can ablate this pattern in the atrium and cause this atria to disappear. Another form of a supraventricular rhythm, which is similar to the one we just saw but slightly different, is called atrial flutter. And again, this is a circus movement of depolarization in the atrium, with often every third or fourth beat getting through the AV node, causing a ventricular depolarization. Let's see an example. Again, it's a circus movement. It usually goes at 300 per minute, often 2-to-1 block, so you get a ventricular rate of 150. And on the EKGs, the flutter waves have a sawtoothing appearance, looks like sawtoothing. Here we see an example. Notice this is a heart rate of 75. So that's, if you divide 300 down to 75, that's 4-to-1. So this is 4-to-1 flutter, and you'll notice the beats occurring. There are some 4-to-1, and then sometimes it'll go to 3-to-1 and 2-to-1. It can go back and forth. In this case, it's 4-to-1. And look at the flutter waves there. Do you see the sawtoothing in between the QRSs? If you see the first beat, that's a QRS, and then sawtooth, 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 QRS. Sawtooth, 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 QRS, sawtooth, and so forth. You'll notice also this patient has a left bundle branch block. They have a wide QRS, greater than 3 little boxes. That pre-existed the atrial flutter. And again, learn this pattern. The sawtoothing pattern means atrial flutter, usually at 300 per minute. You'll notice there's one big box between the saw teeth. Here's another example. Here, beautiful flutter waves. Notice, again, this is also a ventricular rate of 75, so it's 4-to-1 atrial flutter. See how clear it is? Sometimes it's not quite so clear, but in any case, this is another example of 4-to-1 AV block with atrial flutter. And of course, the ventricular rate is 75 per minute. Now, atrial fibrillation is not as organized. It's not a circus movement. In fact, it's chaotic atrial activity in the atria. I like to tell patients with my hand, so this is a supraventricular tachycardia. It's going very fast, and then periodically the ventricle goes. But what happens in atrial fibrillation is this. It's totally random and irregular, the number of beats that are getting through, so you have a completely irregular heart rhythm, as opposed to atrial flutter, which is regular, or supraventricular tachycardia, which is regular. So atrial fibrillation, again, the result of multiple chaotic depolarization waves in the atria. Some of the waves get through the AV node in a random fashion, leading to a tachycardia with a very irregular heart rate. The QRS is usually narrow, again, unless we get to the same thing I mentioned before. The heart rate is so fast that you get a so-called rate-related right bundle, and that occurs only when the QRSs are very close together. So here is atrial fibrillation with a reasonable heart rate, not too fast. Notice the distance between the two the R's of the QRS is completely random. Some are short, some are long, some are medium. So this is called an irregularly irregular rhythm. It's completely irregular, random. And you can do that by, if you have a compass and you put it on the first QRS to QRS rate. Oh, the next one, it's much shorter. Oh, the next one, it's much longer. Oh, the next one, it's intermediate. Oh, it's much shorter. So again, in the next one, much longer. And you'll see little waves occurring there, but they're not organized. They are fibrillation waves, not flutter waves. So the heart rate is more irregular than in flutter. The waves seen between the QRSs are variable in size and shape. They're not nicely sawtoothed. There's no sawtoothing. Here we see, again, this example of a normal ECG, normal QRSs, no hypertrophy, no myocardial infarct, and a markedly irregular heartbeat. Look at the bottom strip. You'll see how totally irregular that is. You don't see sawtooths, you don't see abnormal P waves. This is atrial fibrillation. You can tell it by the grossly irregular heart rate. You can measure out the distances between the two R waves all the way through. Every one of them is slightly different. Occasionally, extra beats will actually develop in the AV node itself. These are so-called nodal extrasystoles. They also have a narrow QRS, but there's no abnormal P wave before the abnormal beat. They originate in the upper AV nodal region. They're not very common. Much more common are atrial premature beats. And here we see some examples. You'll notice that the first three marked with an arrow have no P waves before the extrasystoles. So you'll notice the first beat, there's no P wave in front of it. Then we have a normal beat. The second beat, P wave, QRS and T. Oh, there's another beat there, no P wave. Then the fourth beat, P wave, QRS and T. Oh, and there's another extra beat with no P wave, and so forth. It continues throughout. So these, without a P wave, are nodal extrasystoles. So let's take a look at a case. This is our first case for the 6th lecture. Here's an 80-year-old woman comes to the emergency department complaining of palpitation. She feels her heart bouncing around in her chest. She's short of breath, and I'm going to show you her EKG. By the way, this is what I'd like to joke with the residents. This scenario is as common as dirt. Why is it so common? Because we're seeing so many people over the age of 80. In the United States, in a 24-hour period today, more people will become age 85 than will be born. And I'll bet it's the same in many European countries. And what are we seeing? A huge increase in the elderly population, and this next rhythm is very common in the elderly population. So here's a patient with palpitations and dyspnea, comes to the ED, and here's the EKG. Please take a look at it and come up with a diagnosis yourself. So let me ask you, do you see any abnormal P waves in front of the QRSs? I don't. Do you see any sawtoothing waves in front of the QRSs? I don't. Is the QRS normal or very abnormally irregular? I see it as being very abnormally irregular. So the diagnosis is atrial fibrillation, and this is pretty fast. The heart rate's 150 per minute. Grossly irregular heart rate, particularly if you look at the bottom strip. It's easy to see with the bottom rhythm strip. So, thanks very much for being with us for supraventricular arrhythmias. Please stay tuned for ventricular arrhythmias. So welcome back to the ECG lecture series. We just heard about heart block, and some heart blocks are treated with pacemakers, and so let's talk about pacemakers. Pacemakers are an amazing development. They were developed back in the 1960s, and they were developed for patients whose heart was too good to die, quote unquote. What does that mean? That means people developed complete heart block. They had heart rates in the 20s and 30s. The cardiac output went down, the kidneys failed, and the patients died. At autopsy, the heart looked perfect. The muscle was good, the valves were good, the coronary arteries were good. They died because of an abnormality in the electrical system. That led to the development of pacemakers, which were quite large at that time, placed under the skin and the abdomen. Nowadays, the average pacemaker is a little bit bigger than the watch that you wear on your wrist. And most of it consists of the battery, the lithium battery. And the little chip that does all of the thinking is, of course, very tiny. So let's talk about pacemakers. Pacemakers are used to treat either second-degree Mobitz 2 block. Remember what second-degree Mobitz 2 block is? That's where there are drop beats without lengthening of the PR interval. Lengthening of the PR interval can be type 1 second-degree AV block, can occur in athletes and normal people. But type 2, where you're suddenly dropping beats, do not occur in normal people. That means a lot of injury to the conduction system, and you're very close to third-degree AV block, which means complete heart block with a very slow heart rate and a reduced blood pressure and a reduced heart rate. Patients with high-grade AV block are usually symptomatic. Often they faint because their blood pressure drops. They're hypotensive. And hypotension with a very slow heart rate means lowered cardiac output, and if prolonged, can result in renal failure and eventually in death, as occurred in the days before pacemakers. Syncope or near syncope is very common in these patients, of course, because of the low blood pressure, and the pacemaker therapy is required to restore normal heart rate and a normal blood pressure. So the pacemakers have a code that tells you where the pacemakers are being paced and where they're being monitored and so forth. And I'm going to take you through the code. So when you see the code, somebody says to you, oh, this patient has a DDD pacemaker. You're not standing there thinking, I don't know what that means. So let's see what that means. So the first letter is where the active pacing wire is located. So if the first letter is V, that means the pacing wire is in the ventricle, and it's essentially always the right ventricle. If there's an A, that means the pacing wire is in the atrium, and that's almost always the right atrium. We usually don't put pacing wires on the left side of the heart because little clots can form there, break off, and go to the brain and cause strokes. So almost all the pacing occurs in the right side, right atrium or right ventricle. And if there's a D, that means there are pacing wires in both the atrium and the ventricle, D for dual. Okay, V means pacing in the ventricle, A means pacing in the atrium, D means pacing in both the atrium and the ventricle. So that's the first letter. So the example I gave before, DDD, that means D, the first letter is D, it means it's pacing in both the atrium and the ventricle. And I will show you examples of all of these as we go along. The second letter is where the pacemaker is sensing the underlying rhythm. Because, you know, these days, the pacemakers don't just keep firing. They have a little a chip that reads whether there's an underlying rhythm. So they only fire when there's a failure of the normal beat to occur. So where do they sense whether normal beats are occurring? Well, if the second letter is a V, they're sensing in the ventricle. If the letter is an A, they're sensing in the atrium. And if the letter is a D, they're sensing in both the atrium and the ventricle. So remember the example I said, DDD. Okay, the first D says that they're pacing in the atrium and the ventricle. The second D says they're sensing in both the atrium and the ventricle. They're looking for P waves, and then they're looking for QRSs. Okay, the first two letters are D and D, means the patient's pacemaker is pacing in both the atrium and the ventricles and sensing in both the atrium and the ventricles. So the third letter shows which heart chamber the pacemaker is inhibited. That is, where does it recognize that there's a regular beat occurring and therefore it does not pace. If it's inhibited in one ventricle, there's an I. And if it's inhibited in both the atrium and the ventricle, there's a D. There's another characterization called triggered, rarely used, and really we almost never see that. It's where they're looking to trigger a beat and have it inhibited. That really isn't of any major importance. It's really I and D that's important. Let's see the example. A D-inhibited pacemaker watches first for an atrial depolarization wave and doesn't pace if it sees one. Then it waits and it's looking for a QRS from the ventricle. If a QRS occurs, the pacemaker does not pace. And if neither a P wave or a QRS occur, the pacemaker puts both in. So, for example, it might happen that there's a failure of the atrial depolarization, so the atrium is paced, but then there's a normal ventricular depolarization. The opposite can occur. There's a normal P wave, but no QRS, so the ventricle is paced. Or neither occur, you'll see both atria and ventricle being paced. The fourth letter is really used against special pacemakers that can increase the rate when patients exercise or get excited. Because as we talked about before, the pacemaker is set at a certain heart rate, and it'll always hold that heart rate. But what happens if somebody exercises? They need an increased heart rate. So there are pacers that follow certain physiological variables. For example, skeletal muscle activity or respiratory rate. When they see that increasing, they know the person's exercising. They increase the heart rate, which is what happens in normal people when they're exercising. So when one of those bodily variables, either a skeletal muscle activity or respiratory rate goes up, the pacemaker increases the rate of pacing, and the amount that the heart rate will increase is programmed during implementation, but it really can't increase above 25 beats. But again, if you have a patient being paced at 72 and then suddenly they're exercising, now their heart rate goes up to 97, so that increases the cardiac output. So it makes their exercise more physiologic. The fifth letter is rarely used. It's mostly for experimental pacemakers where multiple sites are being used within the atrium or ventricle. And these are sometimes special arrhythmia pacemakers, for example, to control atrial fibrillation. You almost never see it in routine daily clinical work. As noted, many of the pacemakers are experimental, not used routinely. And clinicians almost always deal with a 3 to 4 letter code describing the pacemaker implanted. And we're going to take some examples. So here is a VVI pacemaker. First V, where's it sensing? In the ventricle. Second V, where's it pacing? In the ventricle. Third letter I, it's inhibited when there is a normal QRS. So the pacemaker does not pace or is inhibited when it senses a QRS in the right ventricle. Here's another example. Here's a DDDI pacemaker. So where does it sense? D, both atrium and ventricle. Where does it pace? D, both atrium and ventricle. Where is it inhibited? Both atrium and ventricle, and that's the I saying it's an inhibited pacemaker in both of those sites. See, again, inhibited in both the atrium and ventricle when an appropriate P or QRS is sensed. In this slide, we see a little diagram, a little cartoon of how the pacemaker is inserted and where it's inserted. As you know, noted from earlier, it's almost always on the right-sided chambers. A wire is usually inserted through a catheter that's placed in one of the central veins, often the subclavian vein, percutaneously, that is with a needle, and the wire is then positioned, either if it's a pacemaker that's in both the atrium and the ventricle, you have two wires, one put in the right atrium, one put in the ventricle, and that's what this little diagram shows. It shows a wire in the right atrium and a wire in the right ventricle. Then a little Novocaine is put in the skin, and then a little incision is made and a little pocket is made under the skin, and that's where the actual pacemaker box itself is inserted, and the wire is hooked up to it, and the incision is closed. And I'll show you a picture of that so you actually see it. You'll notice the pacemaker's not in the left atrium, it's not in the left ventricle, it's in the right atrium and right ventricle. And as I said before, it's because little clots can form on the pacemaker and we don't want them breaking off and going to the brain and causing strokes. And here you see the pulse generator, that's the actual box itself, and you see the two pacing leads, one in the right atrium and one in the right ventricle. And so that's where the wires are that are connected to the box that result in the generation of the impulses when the heart itself does not create an impulse. And you can see here what I said before, the pacemaker is inserted under the skin with the electrodes in the right atrium and the right ventricle. And here you can see the tip of the pacemaker in the apex of the right ventricle. And here's a chest x-ray showing a patient with a VVI pacemaker. That is a single lead in the ventricle, so it's sensing and pacing in the ventricle, and it's inhibited when there's a normal QRS. Look first of all at the right side of the diagram, which is the patient's left chest. You can see the pacemaker there, that's under the skin, and you'll see a wire coming from it all the way down and into the right ventricle. And so this is a typical pattern, a so-called posterior-anterior or PA chest x-ray showing a single lead, a VVI pacemaker in this patient. And here we see the pacer and the wire that's going to go in. You see how small the pacer is in this person's normal-sized palm. It's a little bigger than a pocket watch or a wristwatch, but not very much bigger. And you see the wire is quite small and thin. And here's one that's been implanted. You'll notice the green arrow. There are little clips there closing the incision that was used to make the pocket. And you'll see a little bulge just below those clips. That bulge is the pacemaker. And you see where there's a little patch there, a little Band-Aid. That's where the wire went in through a jugular, through a subclavian vein insertion. Sometimes we'll use the jugular vein, but usually, rarely, it's usually the subclavian vein. And here we see an ECG with pacing spikes. Let's look at the bottom, which is the rhythm strip. Okay, The first beat, the first QRS, has a spike in front of it, so it's paced. The second beat with the green box is just like that. There's a spike and a QRS. The next beat, the third beat, spike and QRS. The next, spike, QRS, spike, QRS, spike, QRS. Oh, a normal beat. And then another normal beat. And then spike, QRS, spike, QRS, spike, QRS. You see this patient, in this pacemaker, in this patient, was appropriately inhibited when there were two normal beats that occurred. So this is an EKG from a patient who is being continuously atrial and ventricular paced. Notice, particularly look at the top line. This is a regular 12-lead ECG. Look at lead 1. Two pacer spikes, one where the atrium was and one for the ventricle. And then as you move across to AVR, again, two spikes, atrial and ventricle. You move across to V1, two spikes, atrial and ventricle, and then across to V4, two spikes, atrial and ventricle. So this is a patient being continuously paced atrially and ventricularly. So this is almost certainly a DDD pacemaker. Here we see atrial pacing. Notice there's a spike and a P wave and a normal QRS with no spike. The next beat, an atrial spike and a normal QRS. Atrial spike covered in the green box, and on the next, those two beats, the green boxes show you the atrial spike for the pacemaker impulse, a P wave, and then a normal QRS. So this is atrial pacing, no ventricular pacing here. Now, there's a special kind of pacemaker called an ICD pacemaker. It can not only pace, just like the DDD pacemaker, because that's what it is. It's a DDD pacemaker. But in addition, if the patient goes into a dangerous malignant arrhythmia, and we're going to talk about those in a subsequent lecture when we talk about ventricular arrhythmias, they're the cause of cardiac arrest. And the ICD pacemaker shocks the heart back to a normal rhythm when a dangerous ventricular arrhythmia develops. So, for example, fast ventricular tachycardia or ventricular fibrillation. I'm going to have a lot of time to spend on that when I get to the ventricular arrhythmia lecture. But those are both malignant arrhythmias that can lead to sudden death. And the pacing component works just like the other pacemakers described, but the shock or defibrillation component occurs only when the pacemaker recognizes a dangerous, life-threatening arrhythmia. And here you see them inserting. You see it's inserted in the same way. The ICD pacemakers are larger because they have to carry a bigger battery, because the battery has to be able to shock a lot more than just the impulse shock. The shock for causing a little impulse is tiny. The shock for defibrillating the heart is substantially larger, so it needs a bigger battery. And here you see it's in the same position under the skin. The wires are the same way. The wires are a little heavier as well for the ICD pacemaker. And here's an example. So here we see an electrocardiogram of a patient in ventricular fibrillation. This is a cardiac arrest. So this is a regular 12-lead ECG. Notice leads 1, 2, and 3, AVR, AVL, AVF, and the precordial leads V1 through 6. Notice that the patient is continuously in ventricular fibrillation. And if you look down at the bottom line, that's a rhythm strip. You see the patient's in ventricular fibrillation, and then there's a big spike there. That's the shock. And the beat after the shock is a paced QRS. So the ICD successfully terminated ventricular fibrillation and then paced the patient until the patient's own rate would come back normally. All pacemakers also contain what I call, they have a little tape recorder, and they store any beats that occur. So actually, if there are arrhythmias, you can actually find that out from the pacemaker. The pacemakers are usually checked every 3 to 6 months. And during that time, there's a readout of what has happened in terms of electrical activity in the pacemaker. So any arrhythmias that occurred during that time period are identified and the physician is alerted. For example, there could be short periods of atrial fibrillation. When that occurs, it's seen and recorded in the little pacemaker recording area, and when the pacemaker is checked, they report to the doctor, oh yes, we saw X number 1, 2, 3 episodes of paroxysmal atrial fib, and they lasted for so and so long. So let's take a case and see how well you're doing with pacemakers. Here's a 77-year-old man. He had a pacemaker implanted at another hospital, and he can't find the card he was given which said what type of pacemaker he received. Now he's being seen at your hospital. You'd like to know what kind of pacemaker he has so you can talk to it through the skin with the specific program that's made for that pacemaker. So I want you to look at his EKG or his ECG and tell me what kind of pacemaker did the patient receive. Here's the ECG. Think about it for a moment. Think about where the spikes are. There are two spikes, one for the atrium and one for the ventricle. So this is an atrial and ventricular dual chamber pacemaker. This is a DDD pacemaker. Thanks very much for being with me today. I look forward to speaking with you at the next lecture on ECG reading. Welcome back to the ECG lecture series. We are going to be speaking about ventricular arrhythmias in this series. Remember that ventricular arrhythmias are those that occur below the AV node. Remember when we talked about supraventricular arrhythmias, we mentioned arrhythmias that occurred in the atria above the AV node. Now we're speaking about arrhythmias, abnormal electrical activity that occurs below the AV node. And it is almost all of these ventricular arrhythmias that occur below the AV node have abnormal conduction through the ventricle, so there's a broad QRS, usually more than 3 little boxes, that's 0.12 seconds. Also, the ST segments and the T waves go in opposite directions from that taken by the QRS, and the beat looks very bizarre and abnormal compared to the underlying normal rhythm. The QRS and ST segments of ventricular premature beats are very different in form from the normal sinus or regular beats, as I'm going to show you in a moment. So, here is a typical premature ventricular contraction, fondly known as a PVC, also called a VPB, a ventricular premature beat. So you'll hear both abbreviation, PVC or VPB. Notice, first of all, there's a wide QRS and it's directed upward in the blue box. Notice that the ST segment in the green box is directed downward and in the opposite direction from the direction that the QRS went. And also notice how different this beat is from the previous sinus beats. There's two sinus beats there. Narrow QRS preceded by a P wave. There's no P wave in front of this beat. It's a wide, bizarre-looking complex with a very bizarre-looking ST and T wave. And that's because the depolarization and the repolarization are completely abnormal compared to the normal underlying rhythm. Here we see 3 PVCs in a row, called a triplet of PVCs. You'll notice first beat is a normal beat, P, QRS, and T. The next beat, normal beat, P, QRS, and T. And then, wow, look at that. 3 big PVCs, tall P waves, abnormal ST and T wave segments. And then following that, we're back to the normal rhythm, P, QRS, and you don't see the T there. Here we see 2 different PVCs in the same patient. So notice in the green boxes, let's look, the first beat is normal, P, QRS, and T, and then there's a beat in purple in the green box. It's a wide, bizarre QRS. They're differently oriented, completely oppositely oriented ST and T wave. Then we return normal beat, P, QRS, T, normal beat, P, QRS, T, normal beat, P, QRS, T. Oh, next green box, another bizarre, widely oriented QRS with the ST and the T wave going in the opposite direction from the direction of the PVC QRS. So notice in this patient, there is more than one focus of PVCs. And so this is called multifocal or multiple originating origins of impulse coming from different areas in the ventricle. By the way, multifocal PVCs are more worrisome than when all the PVCs look the same. What about if you keep stringing one PVC after another? That's called ventricular tachycardia. It's a very fast heart rhythm, usually consists of more than 3 PVCs in a row. And what it is it's a circus movement, not so much in the atrium. Remember, atrial tachycardia was this circus movement around and around. Here, the around and around is occurring in the ventricle, results in a very fast heart rate, which often is very ineffective. Therefore, the blood pressure drops. The patients may collapse or faint. And from there, they may actually go into ventricular fibrillation or cardiac arrest, as we'll show you in a moment. The longer the run, the faster the rate of ventricular tachycardia, the more dangerous is this arrhythmia, since it can deteriorate, as I said, into ventricular fibrillation or cardiac arrest. Here we see an example of rapid ventricular tachycardia. The rate is 180 per minute. The heart does not work efficiently at 180 per minute. The blood pressure drops. This is a dangerous arrhythmia that can deteriorate into ventricular fibrillation. Here's another example, not quite so bad. Here the heart rate is 140 to 150. You'll notice it's very regular, right? Because it's a circular movement in the ventricle, just like supraventricular tachycardia is this circus movement in the atrium. This is the circus movement in the ventricle. You'll notice the rhythm strip at the bottom, very rapid. Here a heart rate of 140 to 150. So the patient might have a blood pressure, but they obviously would be distressed, short of breath, uncomfortable. If they had narrowings in their coronary arteries, they might be having chest pain. Notice that there are no P waves before the QRSs. Here we see an example of ventricular tachycardia deteriorating into ventricular fibrillation. So ventricular tachycardia is the circus movement around and around, and then we go into chaos. Remember I said with atrial fibrillation, the electrical activity is just chaotic. Here we see the electrical activity chaotic, but it's in the ventricle. What happens? The blood pressure goes down almost to zero. This is a cardiac arrest. And very, very fast ventricular tachycardia here at 200 per minute. Again, this is going to be associated with a low blood pressure, close to a cardiac arrest. Some people will call this ventricular flutter. Very fast rate. And this is very, very dangerous arrhythmia, very high risk of becoming ventricular fibrillation within a few seconds and going on to cardiac arrest. And here's ventricular fibrillation. The chaotic electrical activity within the ventricles, characterized by different sized complexes. If untreated, eventually this becomes a flat line and the person is dead. Here we see another example. Here's ventricular fibrillation, and towards the end, there's almost no electrical activity. This is very difficult to resuscitate this patient. You can see total chaos in the ventricular activity. There's a special form of ventricular tachycardia / ventricular fibrillation, has a French name, torsade de pointe. That it comes from the ballet term. So torsade de pointe means spinning around a point, in which they're showing you that there's wide complex ventricular tachycardia and then narrow, and then wide and then narrow. And you notice it looks a little bit like a party streamer. Wide, narrow, wide, narrow. And sometimes even there can be periods of ventricular fibrillation and then returning to torsade. Usually the blood pressure is very low and the patient has cardiac arrest. The QRSs keep changing their direction and sizes like the party streamer. And it's often the result of a drug toxicity. For example, we'll talk about that in a later lecture. For example, many of the central nervous system drugs have an increased risk for the development of this arrhythmia, or it's due to markedly decreased blood potassium or markedly decreased blood magnesium. Here's another example, a little more like a cartoon. Notice spinning around a point. Larger QRS narrow, larger QRS narrow. Notice there's a certain rhythmicity to it. It's also called polymorphic or multiple formed ventricular tachycardia, as opposed to the examples you saw before where all the QRSs looked the same. Blood pressure is zero or near zero. It is a very malignant arrhythmia that can lead to death. All right, now that we've talked about ventricular arrhythmias, let's take a case. Here's a 40-year-old vigorous female. She's seen in the office and complains about occasional extra heartbeats. She feels her heart going flip-flop. It feels like the heart's doing somersaults and then pausing. So she has palpitations, and here's her EKG. Look at the EKG and see if you can recognize what's going on. Notice that there are extra beats occurring early and that the QRS is very differently oriented and different shape from the normal rhythm. And the ST segment is in the opposite direction. If you looked at the rhythm strip down at the bottom, you'll see first there's the standard, and then you'll see normal beat, PVC, normal beat, PVC, normal beat, PVC. Notice QRS is wide, very different from the normal beat, and the ST and T wave are oppositely directed from the direction that the QRS is taking. So these are single premature ventricular contractions and are usually benign in the absence of heart disease. Sometimes if the patient's been drinking a lot of coffee, taking a lot of caffeine, if the patient has been smoking, or the patient has been excited or frightened, you will see some PVCs. They can be benign. Thank you very much for attending this lecture. I look forward to talking with you in the next one. Welcome back to the ECG lecture series. We're going to be talking about the effect of electrolyte abnormalities in the blood and various drugs on the ECG recording. This is actually one of the things that makes ECG reading difficult, in that things besides heart disease can affect the EKG and makes it difficult for you to determine, is this change in the ECG due to heart disease, or is it due to an electrolyte abnormality? However, some of these electrolyte abnormalities give you a warning that something bad is happening, as I will show you in a moment. So let's first talk about electrolyte abnormalities, and then we'll talk about drugs. So what are the different types of electrolyte abnormality? One can have hyper or hypokalemia. In other words, hyper elevated potassium or hypo low potassium in the blood. Similarly, one can have hyper or hypocalcemia. That is elevated calcium in the blood or low calcium in the blood. Or one can have low sodium in the blood, and then of course finally a variety of drugs, which we'll talk about right at the end. But first we're going to talk about electrolyte disturbances because they're so common. They happen all the time, and they cause abnormalities in the ECG that are non-specific. That is, they don't say to you, oh, this is hypokalemia. Let's talk about hyper and hypokalemia first. All right? This is an example of hyperkalemia. Notice how sharp and pointed the T waves are. In fact, my resident who was teaching me when I was an intern used to say, think of hyperkalemia when you wouldn't want to sit on the T waves. You can imagine it would hurt to sit on that T wave. They're elevated and they're markedly pointed. Here's another example. Notice markedly pointed and elevated T waves. And in this patient, the potassium was 6.9. Normal is generally 3.5 to 5.5, although we start to get nervous when we get up into the 5s. This was almost 7. What happens if the potassium continues to rise is eventually you lose the form of the QRSs and you get what's like a sine wave like this. The blood pressure falls and it can be fatal. So here we see what happens to the ECG when the potassium in the blood is low. In green up at the top is a normal QRS, P wave, and T wave. Notice the normal P wave, normal PR interval, normal QRS, normal ST segment, and then a normal T wave. You may have an abnormal U wave. Some normal people will have that, but it is also often seen in hypokalemia. Notice down below in pink, this is a hypokalemic change. First of all, the PR interval is prolonged as opposed to normal above. The QRS may be a little bit widened or slightly abnormal in shape. The ST segment is abnormally downsloping. The T wave is shallow, and there's often a prominent U wave, although that doesn't have to be present. So again, a longer PR interval, depressed ST segment, inverted T waves, and a U wave in some cases. Unfortunately, these changes are not specific for hypokalemia, and they're often read as non-specific STT changes because, as I'll show you in a moment, they can be caused by other electrolyte abnormalities or drugs. So this doesn't give you a diagnostic information, oh, the potassium is low, as the way the hyperkalemia T waves do give you a diagnosis. Again, here's another ECG with a patient with hypokalemia. You'll notice with the blue arrow, the T wave is inverted. The green arrow, you'll see that there's a U wave after the T wave. And there's a depressed ST segment in the green box. And the serum potassium here is 2.8. Again, this is a non-specific ECG. This could occur in patients that have multiple electrolyte abnormalities. Let's talk about hyper and hypocalcemia, elevated and depressed serum calcium, blood calcium. So the ECG changes are modest in hypercalcemia with some shortening of the ST segment and the QT interval. So not very specific findings. Again, you'll notice there's a short ST segment, the blue arrow, and the QT interval is short. Notice the T wave comes early. So this is a short ST segment and a short QT interval. Otherwise, the ECG is not remarkable. In hypokalemia, the ECG changes are even more modest. They include slight lengthening of the ST segment and lengthening of the QT interval. And here we see a little more extreme example. You'll notice in the green box, there's a prolonged ST segment and a late T wave leading to a prolonged QT interval. And here is another example. This shows you a prolonged ST segment and a prolonged QT interval. So unfortunately, patients don't show up neatly packaged. You don't have a patient, oh, this patient just has hyperkalemia. Oh, this patient just has hyponatremia. Oh, this patient just has hypercalcemia. Unfortunately, multiple electrolyte abnormalities occur at the same time, which also makes the EKG not specific in these findings. So again, with multiple electrolyte abnormalities, one can get very nonspecific changes, as I said, often called nonspecific STT changes or diffuse STT changes. And it doesn't make the diagnosis. It just tells you that there's something disturbing the electrical activity. Could be combined hypokalemia and hyponatremia, a variety of other things. And so here we see a typical example. Notice in this first part of the ECG that there's abnormal ST segments, sort of downsloping, and you see that in a number of the leads. For example, lead V2 and V3 also have an abnormal ST segment. And then you'll notice in the green box, very abnormal T wave, sort of a funny looking T wave following the abnormal ST segment. This is non-specific ST and T wave changes. Multiple changes can do this. Hypoxia can do this. Electrolyte abnormalities. You can't make a diagnosis based on this ECG. So, as I said, there are many things that can cause these non-specific ST and T changes. Sometimes it's ischemia. Sometimes drugs will do it. Hypoxia, low oxygen in the blood can do it. Certain infections can do it. Certain CNS diseases, and there's a whole raft of others, which is why we call it non-specific, because we can't make a diagnosis. Remember, this is quite different from hyperkalemia with the big sharp T waves that you wouldn't want to sit on. That's very diagnostic of hyperkalemia. These EKG changes really just say there's something going on, but we can't tell you exactly what it is, but there's abnormalities. Look at the electrolytes, look at the oxygen in the blood, and so forth. So let's look at a few drugs. The most famous drug for changing the ECG is digitalis preparations, usually these days just digoxin. You get a rounded depression of the ST segment, and I think I showed this way back in one of the earliest lectures when we were getting intervals and various other definitions of the EKG straight. Also, antipsychotic drugs, such as Thorazine and a whole bunch of others, can prolong the QT interval. And by the way, as I mentioned in an earlier lecture, can set up the situation for Torsades de Pointes and cardiac arrest. There's a long list of drugs that can lengthen the QT interval and predispose patients to torsade de pointe and cardiac arrest. It isn't just antipsychotic drugs. There's now a whole website with dozens of drugs listed that can prolong the QT interval and set up this dangerous situation where you might get torsade de pointe. So here is a typical ECG from a patient who's getting digitalis. Notice the rounded, sort of smoothly rounded ST segment denoted by the green arrows. This is typical digitalis effect. Sometimes the EKG will be read as non-specific STT changes, but this one really looks to me like the patient's on digitalis. Here's the long QT interval in two little diagrams. You'll notice to the left, here's the normal ECG, P wave, QRS, and T wave, and you can see the length of the QT interval. Notice the long QT on the right-hand side. The P and the QRS are normal, but there's a long pause between the development of the QRS and the occurrence of the T wave. There's prolonged repolarization in the ventricle, and this sets up the situation for reentrant malignant ventricular arrhythmias. Prolonged QT. Many drugs are capable of doing this. Here's a patient receiving an antipsychotic drug. Notice long QT interval. This could be very worrisome. The dose might need to be changed, or a different drug might need to be instituted. Here's a 65-year-old diabetic patient with chronic renal failure who's under dialysis therapy but gets sick, fails to come to dialysis for a week because of stomach cramps and diarrhea that developed after eating at a fast food restaurant. When she comes finally for her dialysis, they get this ECG. What does this ECG show? Notice the pointed T waves that you wouldn't want to sit on. This ECG is diagnostic of hyperkalemia. This patient had a serum potassium of 6.9% because they weren't getting dialyzed. One of the complications of renal failure is hyperkalemia, and one of the things that we do dialysis for is to reduce that serum potassium. This patient missed a number of dialyses and consequently has a serum potassium that's markedly elevated, needs urgent dialysis. Thank you very much for being with me for this lecture. I look forward to being with you on the next one. Welcome back to the ECG lecture series. This is the final one. I'd like to review some of the important points that have been made throughout this lecture series, and then I'd like you to identify some unknown ECGs. You will have seen these ECGs or ones like it before, and so what I'd like you to do is when the unknown ECG comes up, please pause the program, think about the ECG, and decide what your diagnosis is before you go to the next slide, because that one will tell you what the correct answer was. So, some final thoughts. First of all, reading an ECG takes time and practice, it is something that's just like I mentioned before, learning to play a musical instrument. You get better with time and with practice. What you will have gotten out of this first series, is a background so that you can start looking at ECGs. I recommend you cover over the computer or the cardiologist reading, try and figure it out for yourself, then look and see what the cardiologist got. And gradually, as you do more and more and more, you'll become more expert. Almost all ECGs these days in developed countries are read by the computer. But unfortunately, as I've said before, the computer is wrong, particularly about arrhythmias 10–15% of the time, and even sometimes overcalls or undercalls an acute myocardial infarction and a heart attack. So an experienced electrocardiographer, usually a cardiologist, should read the ECG, look over the ECG to make sure the computer is correct. So the reading of an ECG is comprised of first of all, what's your overall impression? Just like with an artwork. And then you do the careful and detailed analysis. The computer is usually right in terms of intervals, PR interval, QRS interval, QT interval. It's not often right when the ECG has a complex arrhythmia. That needs to be done by a human being and overread from the ECG. You need to check on the ECG in a systematic process. So what do? You look first at the heart rate. You look at are there P's in front of all the QRS's? You look at the intervals, PR interval, QRS interval, and the QT interval. What's the axis? Is the axis normal? Normally directed somewhere down in this direction, plus 30, plus 60, or a little bit negative, minus 10, 0. If it's markedly abnormal, rightward axis or marked left axis, that suggests a disease process, either in the conduction system or often associated with organic heart disease. Again, the computer is usually right about intervals, often wrong about rhythm. The ECGs not only contain diagnostic information, but prognostic information. Remember I mentioned the bigger the ST segment in an acute MI, the higher it goes, the bigger is the infarct and the worse is the prognosis. When there's ST and T wave changes along with LVH, the high voltage, that's more serious than if there's no ST and T changes. Here's a cute one. The sum of the total upright R-wave voltage in all leads is a rough measure of left ventricular ejection fraction. The opposite is the important point. If you get an ECG that has very little R-wave uprights in all the leads, it usually means markedly reduced left ventricular function, for example, from cardiomyopathy. And of course, the ECGs must be correlated and integrated with other clinical data from the history and the physical exam. It's the same thing the radiologist tells you in interpreting the chest X-ray or a CT scan. If you give them some clinical information so they know exactly what to look for, in fact, you get a better answer in terms of helping you clinically. And the same is true with the ECG. Looking at the cardiogram when you know something about the patient is often more useful than just reading the ECGs blindly. Remember that minor degrees of squared off ST segment depression may be important in a patient who's had chest discomfort that you're thinking this may have been angina. There may be myocardial ischemia. In the exercise test, we like to see at least 1 millimeter of ST segment depression, but if the patient just told you that they had some chest discomfort and you got an ECG and there was a little bit of ST depression, maybe 0.5 millimeter, that went away an hour later, that's very suggestive of myocardial ischemia, even though you didn't get the full millimeter. Echocardiography and, by the way, MRI and CT are more accurate at predicting left ventricular hypertrophy, that is LVH, than the ECG. However, when you see LVH on the ECG, it implies a worsened long-term prognosis for the patient. So it's usually more severe LVH than is picked up. The echo and the MRI are very good at picking up mild amounts of LVH. ECGs from monitor leads should not be used to draw conclusions about the shape of the QRS or the ST segment. I've seen the monitor leads overread the arrhythmias, calling marked ST elevation and so forth when it was just the patients moved in bed or changed their position. So don't use the monitor lead to try and interpret the ECG. Now I'm going to give you a number of unknown ECGs. Let's see how many of these you can read correctly. Again, pause the program with each ECG before you go on to see the answer and see how well you did. Here is the first ECG. Take your time, look at it, decide what's the rhythm, and are there abnormal complexes of size and so forth? Are there arrhythmias and so forth? Take your time. This is a normal ECG. There's a P wave in front of each QRS. The QRSs are nice and narrow. The T waves are upright in all the appropriate places. You'll notice that the R wave progression, that is the increase in the R wave across the precordium, is perfectly normal. Even in V3 and in V4, already the R wave dominates, and there's not a big R wave in V1, and the axis is normal. The axis is approximately plus 60, somewhere in that range. normal ECG. What do you see in this ECG? This ECG is an acute anterior wall myocardial infarction. Notice that there's ST elevation in leads V1, V2, V3, and AVL, and there are Q waves in leads V2, V3, and AVL. So this is an acute anterior wall myocardial infarction, usually due to obstruction of the left anterior descending coronary artery, and the treatment, of course, is angioplasty to reopen the left anterior descending coronary artery. How about this ECG? This ECG shows an inferior wall myocardial infarction. Notice in the green box, there's a little bit of ST segment elevation in leads 2, 3, and AVF, and there are Q waves in 2, 3, and AVF. This may be an older inferior myocardial infarct. Often the computer will read this as age indeterminate. There's not as much ST elevation as you normally see if it were acute, so this may be anywhere from days to months old. And of course, they're abnormally inverted T waves in V3 through V6 and AVF, suggesting that there's some lateral amount as well of involvement of the lateral wall. You'll notice also out in leads, in the anterior leads V4, 5, and 6, there's Q waves, a little tiny Q wave in V3. That also suggests that this is infero and lateral, possibly due to occlusion of the left circumflex artery. So as mentioned, Q waves in the V leads imply the MI was not just on the back of the heart, but also involved the anterolateral part of the heart. And that would be often the circumflex artery, which supplies some part of the anterior wall and often lateral as well, and possibly inferior back of the heart. In 10% of people, much of the back of the heart is supplied by the circumflex coronary artery. How about this one? Did you see the ST elevation in all the leads? So this is not an acute MI, this is pericarditis. You'll note that there's no reciprocal changes, there's no ST segment depression in opposite leads, so this is not an ST elevation MI, a STEMI, this is pericarditis. Almost all the leads have ST elevation. So if it were an acute MI, you shouldn't see ST elevation except in regional zones, 2, 3, and AVF, or the anterior precordial leads. You shouldn't see it in all the leads as here. This is pericarditis. The lecture on myocardial infarction gave you an example of a case with a young man who developed pleuritic chest pain, that is, pain anteriorly that was worse every time he took a deep breath, and he had pericarditis. What do you see in this ECG? This ECG shows very high voltage in lead 1 and actually in lead 3, quite deep S waves, and lots of voltage in the precordial leads and abnormal T waves. And the diagnosis here is LVH with ST and T wave changes. This might be somebody with long-standing hypertension. This could be somebody, for example, with aortic stenosis. Notice there are also P waves that are inverted, so this is left atrial enlargement, and that often goes along with left ventricular hypertrophy. The hypertrophied ventricle has high filling pressures, and that results in left atrial dilation or hypertrophy. What about this ECG? Did you see the tall, pointed R waves and the tall P waves? So notice, there's a tall R wave in lead 1. Normally we don't see a high R wave in V1, and you'll notice the P waves are very big and pointed, so they're right atrial enlargement, and the fact that there's a large R wave in lead V1, that's over the right ventricle. Remember, that's over here, over the right sternal border, where we see a lot of right ventricular activity. So when we see a big tall R wave in V1, it suggests right ventricular hypertrophy. Normally, remember, you might see a little tiny R wave in V1, but a predominant S wave. And again, these P waves are very suggestive of so-called P pulmonale, or P of lung disease, pulmonary hypertension with right atrial enlargement. You'll also notice the axis here is very abnormal. The maximum R wave is in lead 3. That's plus 120 degrees. So this is a very typical ECG of right ventricular hypertrophy. Right axis deviation, P pulmonale, or right atrial enlargement, and a large R wave in V1. Right ventricular hypertrophy. Patient with pulmonary hypertension from lung disease, patient with primary pulmonary hypertension, patient with pulmonic stenosis, all of them could do this. What's this ECG? Did you see the rabbit ears in V1, V2, and the wide QRS? This is right bundle branch block. You'll notice also in lead 1, there's a late deep S wave, and also in lead V6. But the most impressive thing are the rabbit ears in V1 and V2, and the fact that the QRS is wider than 0.12, that is 3 little boxes. So this is right bundle branch block. What's this one? Did you notice the very wide QRS, upright in lead 1 and also upright in V6? The QRS duration is 0.14, so this is a bundle branch block. No rabbit ears. This is left bundle branch block. Notice the bizarre QRSs in V1, V2, and V3. Big, wide, deep S waves. Left bundle branch block. What about this ECG? Do you see the group beating in this ECG with increasing PR interval? This is type 1 second-degree AV block, so-called Wenckebach block. Often benign, can be seen in young athletes. And you see the drop QRS, increasing PR interval, and a drop QRS. So you had 1, 2, 3, 4 P waves, and then the 5th one's missing. What about this ECG? Here you see a very slow heart rate, probably somewhere in the upper 30s, a wide QRS, and there's no regular relationship between the P waves and the QRSs. This is 3rd degree complete heart block. This patient probably had a low blood pressure and needs a permanent pacemaker. What about this ECG? So this is a trick ECG. Look at the P waves and notice how close they are to the QRS. This is the so-called Wolff-Parkinson-White syndrome, WPW. This is due to an abnormal connection between the atria and the ventricle, so that impulses can get into the ventricle not just through the AV node, but through a so-called bypass tract. The characteristics are, first of all, there's an elongated QRS with an upsloping wave to start with called a delta wave. And you can see that again in leads V5 and V6 as well, that sloping up the wave. That's because there's slow conduction because of early arrival of the impulse through the bypass tract in the ventricle, and it doesn't proceed normally because it's not using the His-Purkinje system. And the short PR interval, that's because the bypass tract is not slowing down the impulse. It's getting early into the ventricle. And these patients can have supraventricular arrhythmias, and these individuals can have ablation by the cardiac electrophysiologist and can be cured. what's in this ECG? This is atrial flutter. Did you see the sawtoothing pattern? This is 3-to-1 and 4-to-1 block with the sawtoothing. Clearly regular rhythm because of a circus movement in the atria causing the sawtoothing pattern. It's 4-to-1 block. The heart rate 75 per minute, and the wide QRS suggests a slightly abnormal conduction on atypical left bundle because the QRS is wide. That has nothing to do with the atrial flutter. The atrial flutter is completely separate. This patient had left bundle beforehand. What about in this rhythm strip? Do you see how irregular it is and no sawtoothing? So this is atrial fibrillation. Notice the different widths of the green boxes. It's completely random ventricular activation by the atrial fibrillation impulses getting through the AV node. What about this ECG? Did you notice the double impulses before each beat? There are two spikes, one for the atrium and one for the ventricle. This is a DDD, or atrial and ventricular dual chamber pacemaker. Notice the two spikes before the QRS. The first spike is the atrial activation. The second spike is the ventricular activation. How about this one? Did you notice it started with ventricular tachycardia and deteriorated into ventricular fibrillation or cardiac arrest? The treatment here is electric shock defibrillation to get the patient back to sinus rhythm. This is a cardiac arrest occurring right in this rhythm strip. How about this one? This is ventricular tachycardia at a heart rate of 140 to 150. There are no P waves, there are broad QRSs, and the rate is very regular. So this is ventricular tachycardia. This patient would be in distress, but might still have a blood pressure. And how about this ECG? This is, of course, hyperkalemia. Notice the pointed T waves. You wouldn't want to sit on them. And the serum potassium in this patient was 6.9 milligrams per cent. What do you see in this ECG? This ECG has non-specific ST and T wave changes. Notice the sort of funny-looking, slightly depressed ST segment in blue and the abnormal T wave coming out of that ST segment in green. And this could be the result of electrolyte abnormalities such as hypokalemia, could be hypoxia, infections. A whole variety of things can do this. It's non-specific EKG changes. It doesn't enable you to make a definitive diagnosis of what caused this. And that brings us to the end of the ECG lecture series. I hope you've enjoyed it, and I hope you'll review it again and practice your ECG reading in the future.